Chairman, you're live.
Thank you very much. Good morning, everybody, and welcome to the Public Health and Community Safety Cabinet panel. I'm County Councillor Fiona Thompson, and I'm the Deputy Portfolio Holder for Public Health and Community Safety, and I'm chairing this morning's meeting. I have an announcement to make before we start the meeting. Due to the coronavirus pandemic, the Council will be holding this meeting electronically. Members of the public may also attend this meeting in an electronic capacity, and there is a link on the Council's website for them to do so. Members of this meeting are asked to keep their microphones switched off until called to speak, and to switch their microphones off once they have finished speaking. Cameras may be left on throughout the meeting if members wish, and cameras should be switched on if and when speaking at the meeting. To indicate a wish to speak, members should use the raise hand function. Use of the chat function is exclusively for voting. At the end of the debate on each item of business, there will be a vote. Members should vote using the meeting chat function by indicating for, against, or abstain, and I will declare the result after each vote. Breaks of approximately 15 minutes will be held every 2 hours. Other breaks will be incorporated as appropriate. We do have some membership changes this morning. We have Councillor Rena Ranger subbing for Councillor Maurice Bright and Councillor Adrian England subbing for Councillor Sarah Bedford. And I have also received 2 late apologies from Councillors Ronnie Hearn and Councillors David Barnard. I would like to remind members, if they have any disclosable pecuniary interests or declarable interests, they can declare those at any stage of the meeting. And I will now ask members to introduce themselves if I call you out, and you could introduce yourselves. David Barnard, we have apologies from. Judy Billing, please.
Good morning, everybody. My name is Judy Billing. I'm the County Councillor for Hitchin North and leader of the Labour Group.
Thank you. Adrian England.
Good morning, Chair. Good morning, everyone. My name's Adrian England. I'm the County Councillor for Hemel Town Division, and I'd like to declare that I also work for the National Pharmacy Association as the Membership Marketing Manager.
Thank you. John Hale.
Good morning, Chair. I'm John Hale, Liberal Democrat County Councillor for Coney Heath and Marshallswick.
Thank you. Fiona Hill.
Good morning, everybody. I'm County Councillor and member for Royston East and Ermine.
Thank you. Rena Ranger. Do we have Rena with us? If not, I'll go on to Sunny Thusu.
Hello, good morning. I'm a County Councillor in Welwyn Garden City, Haldens Division, and I am also employed by the NHS.
And Ron Tyndall.
Hi, I'm County Councillor for Hemel Hempstead St Paul's.
Thank you. And Colette Whitelow.
Good morning, Chairman and everybody. I'm Colette Whitelow and I represent Hemel Hempstead North East. Thank you.
Thank you very much. And I just need to check, Carly, can you see if Rena is in the meeting?
Not at the moment. We are chasing up at the moment.
Okay, thank you very much. Okay, let's move on to minutes. And I'd like to ask the panel to agree the minutes of the Public Health and Community Safety Cabinet panel meeting, which was held on the 9th of September. I do see we have 2 actions outstanding. One was at item 3.5, and that was an update from perhaps which David Lloyd would cover.
Agreed.
Thank you. Can you put that in the chat box, please, everybody? Just waiting to see if everybody has agreed that. Thank you very much. The minutes have been agreed. And just to draw members' attention to the fact that we have had a late item at item 10 on the agenda, and members will have received the late report. Thank you. So moving back on to the, oh, excuse me, I'm having some IT issues this morning. Item 2, petitions. I've not been notified of any petitions. And moving on to item 3, and that's an update report from David Lloyd, Police and Crime Commissioner for Hertfordshire. And David, you're very welcome this morning. And I'll hand over to you. Thank you.
Thanks so much, Fiona. Really nice to be here this morning, and I look forward to just sort of giving some introductory remarks. You've got the report in front of you, and I'll, as always, take questions. Before I do that, I'm also joined today by Lewis, who is well known to you as a fellow county councillor, and we'll sort of, I think, sort of Cox and Bob, I think, is the term which is used, isn't it, in future meetings. Lewis will take some of them. I may well come to others with your permission. Of course, Lewis doesn't to that extent need permission to go to the meetings, and I think that's why it makes a lot of sense for him to do that. And I'm really looking forward to working ever more closely with Lewis. I think he's brilliant, and he's going to be really good, I think, as a bridge between the County Council and the Police and Crime Commissioner's office, and I think that's really good. So one of the things I think which might be really helpful is for him to front on many occasions this as well, because it's about how do we ensure that people have the support they need to be able to do a role. So I think it'd be really helpful for him to do that. But unfortunately today you've got me speaking mainly rather than Lewis, so I'm afraid you'll have to put up with my my approach rather than Lewis's. I think the big issue that we've all got to help together on at the moment is police legitimacy, and I think for the next 6 months we're going to be spending a lot of time reminding people what a brilliant job the police do in Hertfordshire and what an excellent police force we have in Hertfordshire. But clearly some of that is going to be through some of the initiatives that I'm talking about today, so that people remember that they are really safe in Hertfordshire. It's one of the safest places to live and work, and we've all got a responsibility to remind people of that. The incidents which happened in London are frankly chilling. We all know that, and you know, for the record, I know other people have tripped up over this. There was nothing whatsoever that Sarah Everard could have done to change that. She did exactly the right thing, and that is why it is so chilling. But I can assure you that as Police and Crime Commissioner, one of my roles is to ensure that vetting takes place properly, that discipline takes place properly, and that we have a police force which is as you would expect it to be for the county. And I'm pleased to say that I feel that we have got that police force, but we will continue, and the chief will continue to ensure that we keep on top of it. So I think we all recognise that this was a one-off. This to policing was what Harold Shipman was to health. But you know, we still need to trust our professionals, and we still need to use them. And because one professional has done something outrageous, which is, as I think the word I use is chilled, and it really has chilled the whole population, does not mean that every single professional that we have is the same, and clearly is not. So, you know, I think we need to know that, but we've all got to work together around that legitimacy piece. And many of the things that I'm doing, as you'll see in this report, are around how we continue to ensure that the public has confidence in what the police are doing. We've got there's a sort of seasonality, isn't there, about our political lives, and we're in that season of writing plans and making budgets. The plan this time is going to be different. I imagine that many of the outputs will be similar, because I've been in place since 2012, and you wouldn't expect me just to change my mind on everything. So many of the outputs will be similar. but the way we get there is going to be different. Clearly, any politician worth their salt should put up a manifesto first of all before they stand for election, and you would expect that then that manifesto is the basis for whatever, if they're in power, whatever they're doing. If they're not in power, for how they're going to oppose, because that's part of the contract you have with the public. So clearly the manifesto is an important part of what will go into the policing crime plan, as it always has been. But I think perhaps what I've missed doing in the past is to have a proper opinion poll, one which goes out professionally, takes a proper balanced view of what it is that people want and what it is people think. And I'm commissioning that this year so that we've got a proper survey in place which will allow 2,000 residents spread across the 10 districts to be able to say, do they feel safe? What would make them feel safer? What makes them feel unsafe? Do they want to see greater provision of police stations? All of those issues which I think are really important and are at the heart of what we talk about all the time. And I'm really looking forward to what the responses are. But then there are other parts which have to be there, and as I've said before, I'm doing a sort of an applied criminology postgrad at the moment, and one of the things which strikes me is that calls for evidence-based policing and evidence base for what we do. And I'm going very much to look back to where the calls for service are from and where the crimes that have happened, and especially something which, without trying to sound too sort of criminologic about it, where the crime harm is happening, just so that we can make sure that the harm is being met by what the strategic approach is. Clearly, this isn't an operational plan. That falls out of this, but it is a strategic plan. I'm also, and this is part of why I raise it here, I want to hear from colleague-elected people. I want to hear from a public consultation. But public consultations tend to, when you look at the demographics of who responds, you tend to get perhaps more in certain demographics than others, and so very early cut of first people coming back was that there were more people over the age of 80 than under the age of 30 who had responded, for example. Now that everyone has something of value to bring, but we do need to make sure that we hear from all communities and all demographics before we pull everything together. So that's my sort of the overview of the policing crime plan. You'll also have seen, and as I say, the part of, I suppose, the rest of the bits that I've raised for you, or to be entirely transparent, that Chris and team in writing the report have raised for you, are some of the things we do together. The fly tipping initiatives, the road safety funds, and I'm very happy to get into them, but I know that you've got a long meeting ahead, so I'm not going to spend a lot of time talking about those. But those, I think, are great examples, and you'll know throughout my time, both as a county councillor and subsequently as a police and crime commissioner, I really do wish that everything we did was more in concert. I really do wish that we had one plan, one budget, I always say, because in many ways, the things which are important to us are where various budgets and various organisations come together. I think fly tipping is a great example. I think road safety is a great example, where part of it is enforcement from policing, part of it is how you construct the roads from the county, and that's important. Also, violence against women and girls. There's a circularity, isn't there, about what I'm saying here at the outset. It's about legitimacy, and I was mentioning the tragic murder of Sarah Everard. But that has increased, I feel, the fear that women and girls have. Clearly, there's a very wide range of offences within violence against women and girls, and perhaps more importantly, a wide range of locations from the home to the street, and unfortunately, probably the home is the place where disproportionately the violence takes place, and that's really a concern for me. But in Hatfield, for example, the Safer Streets Fund is potentially on an interim basis, but whilst we have underpasses in Hatfield, having them well lit makes people feel safer. So what we're doing there is using Home Office funding to do that. There's going to be around 4, doubtless there'll be around 5, and what would be really helpful is if colleagues sitting around the table today were able to think about where are the places that people don't feel safe in the public realm, where some capital expenditure might sort of change that perception. And Lewis can probably talk at length about what we did in Broxbourne. We've transformed an area in Broxbourne where people used to trip over those who had been taking drugs or drunks in doorways and wherever. That's been transformed by a relatively modest amount of money to somewhere which is a really pleasant location and where we've managed to move on those people. So I think that, you know, that's the sort of thing that we could be doing together. We also, you know, it isn't lost on me with regard to mental health. I get every morning a chief constable's report about incidents of interest. Now, clearly, that isn't a scientific this is what has happened exactly wherever, and perhaps it should be. But every morning I read probably about 2, 3, 4, 5 people who have gone missing during the day or overnight, normally in mental health crisis, or potentially who have impairment through Alzheimer's or some other such organic mental disease. But you know, there clearly seems to be a real issue around how we support people with mental health in mental health crisis, and who have mental ill health. We need to find a way of supporting better. And clearly there's a role for the police to play, but clearly there's also a role for health to play, and a role for county council to play. So I looked forward to us working together. That's probably wraps up everything I wanted to do as an introductory minute. Is that how long I took? But as always, really happy to take questions, and I can see lots of hands waving at me, so happy to work through them.
Okay, thank you very much, David. A little bit over a minute, but we'll forgive you. Can I, just before I bring members in, so can I just ask you to comment on, I think it was the outstanding action from the minutes, which at the last meeting, why might it not be possible for a van to be made available when the location is too close to a permanent road speed check? I wonder if you would be able to comment on that.
I could comment, but probably not answer it. I haven't got the, it's something that I think is just seems wrong. I don't know if anyone else on the, I'm afraid I haven't looked that up. So hands up to that. But Chris is possibly on. Chris, have we found out anything about that?
Yes, the road safety vans that we deploy from the PCC's office are designed to supplement the speed checks that are already in place. They provide advisory letters to speeding drivers. They don't provide fines to speeding drivers, so they're deployed on a different basis than the permanent speed cameras. And we have many calls to the office, and there are various criteria that we need to work through to see whether the vans are deployable in the areas where they've been requested. And sometimes it will be that they are close to an existing speed check. Sometimes it will be that there isn't a clear line of sight on the road. And we do need to obviously prioritise where those 4 vans go. So one of the criteria that we do look at is if there's already a speed check in the area, then they won't necessarily be deployed to that area. There are some nuances around that, which we are working through at the moment. For example, if it's a particularly long road, for example, the Bovingdon Road, there might be a speed camera at one end, but it's actually the other end that where there are concerns from the public and from councillors. So we are refining the criteria at the moment.
Okay, thank you very much for that, Chris. I don't actually recall who raised it at the last meeting. I don't know if anybody on the panel wants to jump in, and are they satisfied with that answer? Was there anything else they wanted to query on that? If not, John Hale.
Fiona, I think it was me who raised it last time in respect to the Hatfield Road in St Albans, which is quite a long road. So I'm pleased to hear that the criteria are being looked at, because it was about a mile from where there is a speed check. I forget the technical term as to where I was asking for the van, and you know, it's where I want the van, ask for the van to be placed is a nice long straight stretch. Yes. Where there's a change in speed limit, and it was where there is definitely a speeding issue, and the permanent sites are either side of it, but some distance away through junctions. Okay. And it did seem to me that the response I'd received from the police as to why it couldn't be there didn't make sense, and I'm glad that it is being re-looked at. But,
okay.
Thank you. I'll pick up on that. I live around the corner, so I know the area well, but I'll pick up on that with the office and get a response to you directly.
Thank you, Chris.
Thank you, Chris. Right, thank you very much, David. We have a queue of people. So Sunny, I think Sunny first, and then John.
Good morning. Thank you, David. Very comprehensive. I always have to make notes when you're giving your...
Oh dear.
The only thing that I wanted to ask was, you mentioned the Harold Shipman issue, and that made a seismic change in healthcare. And as a consequence, we have to do things such as revalidation, which is every 3 or 4 years. We have to show, you know, our competence. There's also something called fitness to practice, which is again, a kind of a regulatory, and you know, to see whether we are doing the right things and are we following guidelines, and a couple of other statutory things that have come in for us. Is it, obviously I don't know policing as well as you do, but are there such mechanisms in the police force at the moment, and are they thinking of bringing in any extra things on the back of recent incidents?
I mean, I could give a very long response to it. The very short one would be yes, and the medium one would be clearly we have a really focused vetting process to get in, and we also do re-vetting. So that is important. I do wonder whether or not the vetting necessarily has sort of picked up with the concerns that we might have currently. So, for example, one of the things which is really looked very closely at is people's financial history, which is really important, because if people are in significant debt, it may well be that they could be subject to blackmail or extortion or whatever. We have not perhaps had quite the same detail around how people act in certain circumstances, and we perhaps, although we certainly do look at people's social media profile, those sorts of things are really quite useful. So we are developing that. Clearly, the real response will come after Louise Casey does her first cut of what went wrong, what are the issues, and I think that'll be a time that we'll look at it. As police and crime commissioners, we across the country clearly have this at the front of our minds as well. I've asked, and it's been agreed, that the upcoming conference which we've having between all police and crime commissioners and all chief constables, as its first item, because I think it has to, as it's a public or it's an event to which the media are going, as its first item talks about what are the early lessons that we've learned and what can we do. So yes, I think it will change much of what goes on. That doesn't mean to say, and I'm always really at pains to point out, there is a danger that, I can't see if the media are here today, but there is a danger that then says you therefore think there's a problem in Hertfordshire. I don't think that there is that problem in Hertfordshire, but I think that to ensure that we don't have that problem, we've got to make sure that we are constantly reviewing how we hold to account. And actually it makes the role of police and crime commissioner even more important. And I think some of the low level complaints that we get through into our office, actually I'd say not necessarily low level, but some of the complaints that come into our office I think we should be using them even better to ensure that we get learning into the constabulary, and if necessary, if we need to get rid of officers, that we get rid of them.
Is that okay, Sunny? Yeah. Thank you for that, Sunny. That was a really, really valid point that you've raised. Okay, so we have John Hale next, please.
All right. Thank you very much, Chair. David, thank you again for attending this month. I know you don't always have to, you're not obliged to come. And also thank you for the approving the grants for the speed indicator devices within Coney Heath Parish, which I did mention to you previously, and thanks very much. What I wanted to ask, and looking at your plan going forward, etc., I think quite rightly you have identified support for victims. You've quite rightly identified that, the primary role of the police is seen to be tackling crime, which is very important. But one of the ways of tackling crime is to give support for offenders to stop reoffending. Where I think I would like to see something more, and whether it's from you or whether it's the Chief Constable area, is on the support for the police officers, especially the vast majority who are not the bad apples in the barrel. And I wondered if you could say a little bit more about how you and the Chief Constable are looking at supporting the police officers.
I think you highlight a really important point. Our police force, and if you like, it's the other side of some of what I was saying earlier, but legitimacy in police is through what police officers we have, and even if it were just for that, it means that our police officers need to feel well supported and need to have the right things in place. We take part every year on the constabulary. So at the outset, I'm not the person in charge of police officers. So clearly, I can't say I'm going to do this or do that, because it isn't for me to do. That is for the Chief Constable to do. I know that the Chief Constable takes it very seriously. We're at the moment looking at whether or not we are paying sufficiently, because we may well need to look at the South East allowance again to see whether or not we can do that. We have an annual survey which Durham University help us with to make sure that the mental well-being of our officers are, in general, how easy it is to work at the constabulary is understood. We take that very seriously and then make changes as necessary. Being a police officer is a really tough job, and it's a job that I suspect none of us would wish to do in some ways, although I think some on the call may well have been police officers themselves. I always take my hat off to what they do. We really owe it to them to make sure that their working environment is the one which they should have. You will know that one of the things that I'm having to look at the moment is how we make the places that they work fit to work in. So we've got a considerable capital program coming up about how we refurbish offices which aren't fit for purpose, how we refurbish police stations which aren't. All of it comes in to ensuring that we have a fit and healthy workforce, because they will provide an even better support to the people of Hertfordshire.
Okay, thank you. Is that okay, John? Thank you.
Thanks.
I'm conscious we have 5 more members wishing to ask questions of David, and just conscious of time, so I'd be very grateful if you could keep your questions quite succinct, please. Colette, next.
Thank you, Chairman. Good morning, David. Good to see you. I will be as quick as I can. This starts out as the local question, but it has wider connotations. And I note that crime as a whole in Dacorum does seem to have gone down, but sexual violence, crimes of a sexual nature have increased. Is this local, or does it reflect the county picture? And is it perhaps a reflection of the Sarah Everard case, where people are picking women are picking up much more on the fact that misogyny now is being treated far more seriously, and also people are beginning to appreciate that misogyny is not necessarily reflected in domestic violence. They really are 2 different things. can you give us some comments on that, please?
Oh, I can give lots. I've got an eye on Fiona because we've been told about time, so I'll that's almost an annual lecture there. First of all, I didn't mention yesterday, I think it was, the Office of National Statistics in their crime survey of England and Wales said that crime is down in Hertfordshire by 7%. I always tend to use that with care, but that's a significant drop off in crime. I use it with care because it rates all crime as the same, whether or not that's a murder, rape and sexual serious offence, or shoplifting, and clearly not all crimes are the same in terms of crime harm, so I tend not to go long on it, but still that says things are in the right direction. Also, we're significantly down on where we were in 2019. I think about 15% down on where we were in 2019. Again, that is brilliant news, and I think that it's something worth celebrating. Sexual violence is always a really, really difficult one to work out. It's one of those crimes where the reporting of it going up is in itself a good thing, because people have tended not to report sexual violence. But it would be very difficult to say that sexual violence crimes going up is good, because clearly if that means that if everyone is reporting it and sexual violence is going up, that means that we're not getting that right. Overall, I don't think that in this country we get how rape and serious sexual assaults, RASO as it is called in the trade, is supported. And overall in the country, there is something like it's been estimated that something like 0.5% of all people who've been assaulted actually get all the way through the court process to a positive outcome. Some of that is because the matter is difficult to prove. It's a matter of consent, and consent normally between two people, normally without witnesses, and that is really difficult to prove. But that doesn't mean to say that we've got it right so far. Specifically within decorum, I'm afraid I don't know the answer. I haven't got that in front of me, and I can't comment on the decorum piece, but I think you can see where I'm thinking more broadly, and RASO is an area that all police and crime commissioners up and down the land are very much focused on, because we've got to get it right. And there is currently the Prime Minister has a task force looking at it, and I really very much hope that it will manage to help this. With regard to misogyny, domestic abuse, again, a huge amount that one could say about it. My personal preference is that we don't make more and more crimes out there. I think that in many ways we should be able to we should be able to prosecute via other laws out there. However, I'm always willing to listen to what other people say, and I recognize that another characteristic is a gender characteristic, and if people are being persecuted because of their gender, that is as much of a hate crime as if you're being persecuted because of your sexuality or being persecuted because of your ethnicity. So, I recognize that for anyone who is the victim of crime, it is somehow worsened if it's because you are part of a group and or a community, and we need to be really careful how we prosecute that.
Thank you, David.
Thank you, Colette. Rena. Welcome.
Thank you. Sorry, I was technical. David, recently I'm a district councillor as well, and at Three Rivers District Council we passed a motion. I've always found it unusual that we can have highways liaison meetings in district councils where you can have all stakeholders, residents associations, parish councils, residents come to talk about their highways issues, but we don't do the same for community safety, because it is all those people who know their communities best, and there are different funding pots available through parish, yourself and government grants. And the other thing that it strikes me is that land ownership is very complicated. A car park could be owned by a district council. The pathway to that is under the county's responsibility, and maybe there's a bit of land that, you know, is something else. I really would like you to consider rolling that out across Hertfordshire, perhaps using those district councils and doing safety liaison meetings where you have all those various stakeholders and funding pots that may be available all in one place, so that there is a more holistic picture to having some of these issues, especially as we're saying in this kind of environment we're in.
Rena, just before David comes in, so you do know the police and crime panel has a district and borough rep attending?
But with residents associations and the parishes, and it almost goes to more of a little mini public forum with all those stakeholders who come together, who know the back streets or the alleyway, or there is, you know, it's almost like community safety really to the grassroots level up.
So yes, I entirely agree with you. Where it works well, community safety partnerships, which are the responsibility of the borough or district, actually pick up all that, and there are some brilliant community safety partnerships across the county. Some sometimes lose their way a little, but broadly, you know, they work relatively well. One of the things actually which has been asked in the review of PCCs is whether or not PCCs should formally be part of those community safety partnerships, which we're not formally at the moment, and indeed whether or not PCCs should be able, so some places have delegated that to the upper tier authority. So I think Norfolk, for instance, has one community safety partnership for the whole area. I think actually that, and you'll know my view is that it's really important that we focus on a borough level, and that's why, you know, my undertaking and commitment remains one, at least one police station in each borough and district, at least one chief inspector in each borough and district, and we've also got the community safety partnerships, which should bring everything together. So where it's working well, I think we're already doing it, but I know what you say, and I think that Chris also is on the line, and we'll take that away to see if there's some effort which needs to be redoubled. Perhaps we also need to make sure that it's redoubled from the politicians very locally, and you might want to push that.
Okay, thank you, Rena. Judy, and then Adrian, and then Fiona, and then I think we'll move on after that. Judy.
Okay, I didn't come online to comment, excuse me, on what Rena's just said, but I would say that we do quite a lot of that work in North Hertfordshire, and it suffered badly through the pandemic, and it doesn't always manage to be at the top of the thought processes of the entire police force. So as politicians, we have to keep reinforcing it and asking for it and pushing for it. But I'm more than happy in a non-political sort of way to talk to Rena about that offline if she'd be interested.
Thank you, Judy.
So that's one thing. The other thing I wanted to raise, which wasn't about that at all, and will possibly sound self-indulgent, but it's not meant to, and is about the safety of public servants, and what thought, discussion or anything has been given in the Office of the Police and Crime Commissioner to keeping MPs and a few hundred councillors safe in their daily work, because not because we're any more important than anybody else, but because there is a growing demographic deficit, I feel, of people unwilling to participate in any of the daft activities that we all get involved with. And that's a real shame and a real worry. And in recent years, of course, it's come very much to the fore, and in recent weeks even more so. So I know what we're doing in North Herts about giving extra safety to councillors in surgeries and that sort of thing. But I just wonder whether there's any central thought going into that.
I think there is central thought, sort of parliamentary thought. Clearly, I would and the Police and Crime Commissioners also wish within that self-indulgence to make sure that they too are safe. I've been involved in local politics since '92, as you probably know, and certainly whilst I can't evidence that it's got less safe, I certainly feel that the time has come for us to make sure that we are looking at people's safety. The premise is that you started with was, what is the Police and Crime Commissioner's office doing? I'm not sure that it's the office which needs to be the starting point of it, although clearly I don't wish to sort of get in the way of it. In many ways, we're talking about something operational, and in many ways, we're also talking about something which we all need to do for ourselves. I met with a councillor recently who I don't need to name, but to talk this very thing through, and I think it's fair to say that there probably is something. Sally Phillips, who you'll know from the days as Chief Inspector for North Herts, has moved in and is now the sort of the staff officer for the Chief Constable. She was in the meeting as well, and I suggested that there may be something that we can get the community protection team to come and discuss, either at a group meeting or across all county councillors, around what you might be able to do about personal safety. It's really important that we do. It's really difficult, isn't it? Because we want to be accessible to the public. We want to listen, and very often the people who want to contact us are vulnerable people, are very often people who have complexities which are difficult to support. And then at the same time, some of them may have issues such that, which they feel really strongly about, and perhaps will be violent. And that is really difficult about how we support those people appropriately, but at the same time keep ourselves safe. I suppose what I would say is I think that we are in an opportunity now for us to be able to do things online a lot more, that we can have surgeries online a lot more, but of course a lot of what we do is via email, is via phone or whatever. But I do think that we've got to look at the surgeries which we properly hold not being in people's homes, but actually being in public places where we have got some other people there to ensure our safety. But tragically, I've used the word too often, haven't I, during this meeting, but tragically for Sir David Amos, that didn't work. And, and there is a list of people for whom it hasn't worked. But I think, for example, I don't go to people's homes any longer. I did as a county councillor. I don't do that any longer. They've got to come in. Well, they don't. I will find a place that we can meet. But I suppose for me, being able to meet in a police station or somewhere like that does focus the mind a little bit. And I always have an officer present with me. And I think that you all should think about the same thing, about ensuring that you have if not an officer, at least someone else, but ideally an officer, to take a note apart from anything else.
All of that, thank you.
Thank you, Judy. Yeah, very important topic, because as councillors, as you've said, we need to be available for our residents. But actually, it's about managing the risk. And I think we've all received recently some guidance from, I think, the LGA, and I know there's some training sessions, member development sessions coming up in the next couple of months, just to remind people about, I suppose, good practice and just how to take additional safety measures to keep people safe. But yeah, it is a growing concern. Thank you, Adrian, Fiona, and then I think we'll move on. Adrian next.
Thank you, Chair. Good morning, David. And I guess maybe I declare another interest that my wife is a special constable. So she gives me a bit of an insight sometimes. Very interesting. As a substitute on this committee and a newish councillor, I'm perhaps not completely across the background to the vans. But is the PCC liaising with MPs regarding the placement of speed vans?
Short answer, I liaise with anyone. So I can liaise with you, or my office will liaise with you. But clearly, if an MP also says that he's got or she has got a concern about where there are speeding issues, I will listen to them as well. So and can I thank your wife for being a special? We can bring another one in. If we can all bring another one in, that would be even better still. But thank you. She does that really difficult job and doesn't even get the benefit of being paid for it. So thank you.
Indeed.
Is that
Chair,
okay,
Chair, if I may just explain why I'm asking that. So Mike Penning, the MP for Hemel, has recently suggested in the media that David Lloyd's enforcement speed cameras could be deployed outside schools to enforce 20 mile an hour. But it seems to me that these won't make the road feel any different. Therefore, it's logical to conclude that HCC wouldn't support them at present. So is he and do you seem to be agreeing with the principle of defaulting to 20 mile an hour?
The issue of 20 mile an hour is not one for me. You know, I am interested in what people think about it. You know, I haven't got any comment to make around that. The issue of vans is an important point you make. The issue of vans, in many ways, my ones are around where people think there's a problem, rather than where there is a history of road traffic collisions or enforcement need. So that's why they're slightly different, in that they don't give a ticket to you, they send a letter. All of those things are the difference. So this is just to remind people what the speed limit is in the area. It also, of course, I think, adds to the evidence, so that if there is a problem, then we can bring enforcement in due course. But it's really just to remind people. It's about proper policing. It's about establishing legitimacy still.
Yeah, thank you, David. And of course, regarding the 20 mile an hour speed, the idea is they will be assessed on individual basis, as you're probably aware, Adrian. So there is scope to have 20 mile an hour outside schools, but of course it is looked at on an individual basis. Thank you. Fiona, you're next. Thank you.
Thank you, Chairman. Morning, David.
Fiona.
Firstly, I would like to thank yourself and Lewis for all the support you've given in my division regarding speeding. Some really positive things happening with the vans and other measures as well. So thank you for that. My question has already been touched on, but there's been a great deal of joint working regarding domestic abuse. Are you noticing a significant positive impact on the figures as a result yet?
It's probably a little early for us to. It will always probably be a little early in some ways to be certain. But I suppose what I'm really pleased about is that in 2012 we didn't really talk about domestic abuse at all. Now we recognise the issue it is, and we are working well together to ensure that the support is there. It's an incredibly difficult thing for people to do, to actually to report domestic abuse and to do something about it. The evidence suggests that people do report it sooner than I always felt it was, which is good. The evidence is that the impact of domestic abuse drops off, so that the worst abuse takes place earliest rather than later. But that might suggest that those in an abusive relationship move out of it, and that might be why it drops off. So there's still some work to do around that. But I think early on, yes, I'm pleased that we're talking about it, but I don't have those figures in front of me to say there is definitely a benefit from it. I don't know anyone else whether or not Chris. I haven't got my phone next to me, so he's probably at this very moment WhatsApping me to give me the numbers. If he is, he might want to say now.
I don't have the numbers to hand, but we can look into that and come back to you about it.
Yes. Perhaps you could forward them.
Yeah.
Yeah. Thank you.
No problem.
Thank you very much. Thank you, Fiona. Well, thank you, David, and thank you, Lewis. As always, a great debate and a very comprehensive update. And what you started with, which is about maintaining public trust in policing, I think is going to be one of the big challenges going forward. And it is always unfortunate that, to coin a phrase, a few bad apples then just taints the whole barrel. So we welcome you coming back in due course to let us know how things are progressing. So we're always very grateful to have you here. Thank you very much.
Always pleased to be.
Thank you.
And Lewis will do an even better job and probably wouldn't take 50 minutes of your meeting. So I apologise for that.
Please don't. It's an important issue and it deserves the time it takes. So members, we are asked to note the content of the report. So if you could type that in the chat box, and just a reminder, the chat box is only for agreeing items. Thank you. We'll just wait, and then I'll thank you, David and Lewis, and I'm sure you're extremely busy, and if you need to get away, then absolutely.
I've got my 7th Force meeting at 11 o'clock, so it all works perfectly.
You'll just have time for a cup of coffee.
Exactly that.
I think that's nearly everybody. Are we waiting on anybody else? Noted. Noted. Okay, thank you. That item has been noted. Thank you very much.
Thank you.
Thank you. Bye-bye.
Bye.
So the next item is agenda item 4, and that's Police and Crime Panel, and that's update from the council's representative, and that is myself. Disappointingly, I don't have much to report. So the meeting on the 23rd of September, which was due to be held, actually turned into an informal virtual meeting without the Police and Crime Commissioner. And actually, we just focused on we've established 3 subgroups to move forward to get a greater, I suppose, to focus, really drill down into several aspects. So we've set up a finance group, a disproportionality group, and prevention first. So I'm afraid I don't have too much to report back on that. The next meeting is on the 25th of November. That is a formal meeting that will be held at Broxbourne Borough Council, and as always, the minutes would be circulated afterwards. I am happy to take questions, although I'm conscious that I really don't have much to share with you. Okay, and I don't see any hands up, so there are no recommendations. This is just a verbal update. Thank you very much. So moving on to agenda item 5, and that's the whole systems obesity update. Delighted to welcome Victoria Lightner, the Strategic Advisor for Healthy Places, and Tizzy Keller, Public Health Registrar. Good morning.
Good morning, Chair, and good morning, everyone. I'm Victoria Lightner. I'm the strategic lead for the wider determinants within Hertfordshire Public Health Team. And yeah, we're bringing this item of the whole systems obesity approach to you this morning, just to give an update on the work that's been going on over the last 18 months, I guess. And Tizzy will give a more detailed update. So I'm going to start with a bit of an overview of where this piece of work sits for those who are not overly familiar with the public health world. So obviously we sit within Public Health Team, Hertfordshire County Council. There are several different portfolio areas within that, and we are part of the Health Inequalities portfolio, which is headed up by the Consultant of Public Health, Claire Lauren. And as part of that, so health inequalities is the wider umbrella topic, and within that we have a wider determinants team. with 2 sub-projects, one being a Healthy Places team and one being the whole systems approach to obesity. So in terms of tackling obesity in Hertfordshire, there's several different work streams going on. So the whole systems obesity work is more an approach, which is a national approach to tackling obesity from all different angles. So it encompasses a way of tackling environmental issues and place-based issues, as well as linking that up with behaviour change interventions. So whereas the wider determinants team, so us, are looking at the wider systems approach, bringing people together through the Hertfordshire Obesity Partnership, which has strategic oversight of the issue, as well as the Healthy Weight Network that we've brought together, where we've brought together the NHS, providers, commissioners, and all people that have an interest in improving the health or promoting healthy weight of our residents. We also then commission services in other departments in public health, such as the health improvement team and the children's team, where we have a specific intervention that we commission for our local residents. So for children, there is the Busybody scheme, for example, which is a healthy lifestyle program for children families, as well as we commission WW for our adult population, and we work in close partnership with the CCG to commission specialist services at the latter end of the scheme. So to make sure the obesity pathway is covered from all angles, from universal services, promoting and raising awareness, all the way through targeting those who may already have an unhealthy weight, all the way through to specialist services commissioned by the CCG. In terms of whole systems obesity approach, like I said, it's an approach and an overarching strategy to bring all people in Hertfordshire that have an interest in this topic together to work on this from all different angles. And from a wider determinants point of view, we look at things like access to healthy food. So that's included in some of our planning applications that we review in regards to fast food outlets, for example, where we make recommendations and as to putting in healthier outlets, for example, as well as creating active environments. So we work closely with our colleagues in highways and transport to promote active and sustainable travel. What else? And just generally bring in the behaviour change interventions and the environmental side of things together. So I think that's probably enough of an update from me, and I will now hand over to Tizzy to give you a detailed update on the actual work that's going on. Thank you.
Thank you, Victoria.
Thanks, Victoria. Hi, I'm Tizzy and I'm a public health registrar. So as Victoria said, I'm going to talk a bit about two of the work streams within the whole systems obesity approach that this specific report updates on. So I'll just give a brief overview of what's in the report and then obviously happy to take questions. So the first work stream is the food poverty needs assessment. The food poverty needs assessment started work on that about a year ago, last October, and was completed in August this year. It provides really important and interesting insight into the issue of food poverty in Hertfordshire. It highlights that about just over 10% of the Hertfordshire population is at highest risk of food poverty, which equates to about 123,000 people. It also highlights which groups are at highest risk, noting groups like young people, people on low income and single parent households being at highest risk of food poverty, and also looks at a geographic basis which areas in the county are at highest risk. So it notes that Stevenage, Watford and Broxbourne are the areas at highest risk based on a number of different risk factors of food poverty. There's some really interesting and useful maps in the needs assessment which look at kind of location of supermarkets across the county, highlighting which areas might not have as good access to supermarkets and affordable food. Part of the needs assessment as well was some research which was undertaken by the University of Hertfordshire, which is some qualitative research into food poverty in the county. They undertook interviews, focus groups and a survey with residents and stakeholders, so services, people who work in services addressing food poverty in the borough, and they kind of provide some really, really important insight into the experience of food poverty for people who either are experiencing it themselves or working very closely with people who are. All of this information has been brought together to come up with 4 main recommendations in terms of going forward for this piece of work. So those 4 recommendations are establish leadership on food poverty, develop a Hertfordshire Food Poverty Alliance, develop a Hertfordshire Food Poverty Action Plan, and develop a Hertfordshire Food Aid Network. We've developed some KPIs to kind of highlight the immediate next steps for these recommendations and to track progress of this work over the next year or 2. And this work is being overseen by the Building Life Chances Steering Group, which brings together public health, adult services and children's services. We're also in the process of recruiting for a food poverty lead who's going to really lead on this work and take forward those recommendations. So that's just an overview of the food poverty side. The other project that this paper updates on is the place-based approach pilots. So there are currently 2 pilots happening in the borough that are testing a place-based approach to healthy living, and in particular healthy weight, in the areas of kind of greatest need. So all districts and boroughs were invited to apply to take part in these pilots, and 2 places were awarded the funding. So they were East Herts and Stevenage. Both areas have kind of highlighted and chosen specific areas to focus this work on. So in East Herts, it's Seal Farm, and in Stevenage, it's Sheffield. And they're both at the engagement stage of their work. So they're both about to launch surveys and are working with residents, speaking to businesses, speaking to schools, speaking to local people to understand the issues and the barriers to healthy living in their area. Then they will be working with the communities to co-design solutions for these issues. And then from April next year, we'll be beginning to implement them. So the implementation phase will last from April to December next year. And then there'll be an evaluation phase looking at what was done, what worked well, what didn't work so well, to really build the evidence in terms of this place-based approach to addressing healthy weight. Following that, there'll be an evaluation phase. And then we'll look at how we kind of implement the learnings wider across the county to make sure that all the work that's being done over the pilots is stuff that can benefit, everyone across the county. So that's just a very brief update of what's in the report, but very happy to take questions.
Lovely. Thank you very much, Tizzy. Just a quick question from me before I throw it open. So you mentioned on the food poverty needs assessment, work had been done, and I suppose actually it also applies to the place-based approach. Work had been done looking at the availability of supermarkets, location, etc. Have you also looked at, fast food outlets, places, and then joined onto that in terms of moving forward? Will you be also talking to planners in district and borough councils? Because I think there is a definite correlation. We know about, there's been much talk about location of fast food outlets near schools, etc. And that's a really key factor, I think, to be looked at.
I can start and then I can hand over to Victoria, who knows more detail about the work we do with planners. But in terms of, yes, essentially, fast food outlets are definitely being looked at in both the food poverty work and in the place-based approach. I know in the place-based approach, for example, I think the surveys in both areas are asking people about different food outlets, different fast food outlets, how often they use them, and we'll be looking at that kind of things to think about kind of how people access food, what food people are accessing. So yes, and like I said, Victoria can talk more about the work being done with planners.
Thank you.
Yes, certainly. This is something we are going to look into a bit more in the next coming months, as we are going to update our health impact assessment or the position statement from Hertfordshire County Council around the planning side of things. And we would very much like to start working more on the that work stream around access to healthy food. That includes a big mapping exercise around where the unhealthy food outlets are, especially around educational settings, you know, schools, secondary schools in particular, but also earlier settings and the rest, to map that out. And then the view is to actually incorporate some policies into the local plans and maybe put some thresholds in as to, you know, when an application comes in, that we can review it under those different public health aspects. So at the moment, we're looking at things like social well-being, we're looking at air quality and those kind of things, active transport and travel, which is somewhat related to obesity as well. But we want to narrow that down a bit more, focusing on fast food outlets, where are they being placed, and are there other alternative options that could be put into there to ensure that there's a healthy balance of options available in each area. So that's ongoing work. Some of the district and boroughs have already started that, but there's still quite a lot of more work to do. But hopefully in liaison with the food poverty needs assessment, we can draw out some of that and try and link it into the health inequalities work that we're doing to drive that forward. Yeah.
Okay, yeah, thank you. That's good to hear. Thank you, Victoria. Okay, so waiting to ask question or comment is Adrian first, please.
Thank you, Chair. Thanks, Victoria and Tizzy. I think I'm struck again by the analogy between the climate emergency situation that we all understand and the obesity emergency, if you like. They're both driven by our habits. They're both driven by the availability of choices, which we didn't used to have, but now we do. So there's, I don't want to go massively environmental at this point, but I just think there's a connection there. I'm glad that you mentioned supermarket deserts, and can I suggest that the variation between retailers and the meal habits which derive from their brand offer and that they supply are quite key here. Some areas have Waitrose and a Sainsbury's, some have a local convenience store or an Iceland or an Aldi if they're lucky. How do we get the supermarkets to consider in their strategic planning, as well as the limits on planning that we might be able to put? And how do we get them to consider their merchandising so that they're thinking about public health needs more carefully, in addition to the available market for their own corporate brand?
Who wants to take that, Tizzy or Victoria?
I can start. I'll just note that one positive thing that is noted in the report is that there isn't a significant difference in terms of journey time to supermarkets, and I think that's specifically talking about the big supermarkets, depending on deprivation. That was some analysis that was done in the needs assessment. So that's, you know, a relative positive, but like you say, obviously that can mean a lot of different things. Supermarkets can mean different things, and there's lots of variation in that. And I agree. I think in terms of working with supermarkets, that's a really key next step, and will definitely be, I think, incorporated within the recommendations in terms of the taking forward the alliance and working with different stakeholders. I know that there's good work that's happened across the country in terms of working with supermarkets. I'm quite new to Hertfordshire, I should mention, so I'm not sure how much has happened here, but I know that there's work that's happened where I used to work in London that can be kind of learnt from in terms of working with the big retailers, looking at how things are promoted in supermarkets and looking at the affordability of healthy food. So I'll just start to say I think that's definitely going to be incorporated into the next steps, but I don't know if Victoria wants to say anything else.
So I think generally there's quite a lot of work already going on and with the big retailers in the supermarkets. So because the focus and the shift is going more towards, the well-being side of things, and obviously linking up health and well-being with the consumption of food. I think generally there's a lot of work going on already. So I think it's liaising with those people and getting our message out. But I think it's also about educating the population in what healthy means, what it is, and and being more sustainable. Because I think most supermarkets are already going down that route, choosing a healthier packaging in a way that obviously is more sustainable, and those kind of things in line with the COP26 and all the discussions that are going on at the moment, reducing carbon footprint and all of that. So I think there is a lot of work still to be done, but I think a lot of stuff is already happening in the background. I think it's important for us to sort of make those links with the supermarkets or with the retailers, tell them about what our local strategy is and try and get them on board to help us get that message out. Because every supermarket has healthy options and unhealthy options available. And it's down to the people who go and shop there to choose what they're bringing home. And I think it's that bit that from a public health point of view, we need to promote a healthy way more and educate people around which choices to make. And I guess we can only limit some of those things, like I said, through the planning applications. We can have a look and see what fast food outlets we would allow to be put in within close proximity of educational settings, but it's still not going to stop people from going there, or then they go to the next one that is probably just a bit further down the line, further down the road, but I think it's educating people around making that choice, but driving it from a whole systems way. And you're right, getting supermarkets on board to help us get that message out and promote more of the healthy choices than the unhealthy ones. Yeah.
Thank you. Is that okay, Adrian? Yeah, thank you. Next, Ron, please.
Thank you, Chair, and thank you for the report. I'd like to concentrate on the finance, unfortunately, which is actually going to be, I think, a major issue over the coming months, and particularly with the pilots, obviously, but also I'm very interested in the building life chances, because I think we've had some generations of children badly affected by COVID over the last 18 months. And so I think, we are duty bound to do all we can to build up their life chances. And I just wondered if either of you could comment on the sustainability of the funding for both the pilots and then subsequently, hopefully, a rollout programme across the county, and also building life chances as to whether or not this is just going to be an exercise for a year or two and then suddenly the funds run out.
So this is definitely a more of a long-term project. Adult services, children's services and public health have got together to tackle, I guess, health inequalities in the widest sense. So there's several other aspects of the building life chances that are linked to this. We're also working on some workplace stuff and the unemployment side of things. So that's a different work stream. Obviously for our team, we're only focused on the food poverty needs assessment because it's linked to the tackling obesity. But as far as the place-based projects are concerned, there are pilot projects at the moment, and like we said, everyone was invited to put something forward, and we've awarded to borrowers with that money. And it's basically for us in the meantime to get some insight in what works locally, to actually work with our communities to tell us, rather than us trying to impose something on them that we think might work. We have released some funding to work with the communities to tell us what they want and what they think will work. And once that piece of work is concluded, which will again happen over the next 18 months. We're still in the phase of setting it up. Implementation phase will be next year, and then there will be an evaluation phase. And what we're hoping to do is, from the evaluation and from the insight we gain from that, to take that on and draw the learning out, and hopefully then widen offers of those projects across the county. So it's definitely a more long-term project, because we're very aware that we're not going to tackle health inequalities, food poverties, and creating better life chances in a year's time or 2 years' time. So we're definitely focusing on this for the next number of years. And there's a significant amount of money, to answer your question, and that put down for that to look at several different aspects. And that will continue over the years to come.
So ultimately, the idea is that the results of the pilot could actually form further in streams within building life chances. So it's actually to advise on future development of that programme.
Yes, yeah, certainly. So we're trying to get as much insight as we can from that and learn from it, and then whatever our findings are, apply those going forward and widen it.
Okay, thank you very much. Thanks, Chair.
Thank you, Ron. And of course, yeah, the pilot is just the first step, isn't it? Because as you say, you can't solve these problems, you know, in a short period of time. They are longer term projects. So I think the Building Life Chances project is an exciting one, and actually, as we see, obviously the proof will be in the pudding. When we see the outcomes, they're going to be critical to see how things improve. So we look forward. So will you be bringing back an update in due course, or 6 months, a year? What would be timely?
Yeah, I think we were talking about giving an update once the implementation phase is underway, and we then have some tangible things that we can report back.
Okay, thank you very much. John.
Thank you, Chair. A couple of aspects I wanted to comment on. One is we spoke about, or you talked about fast food outlets, etc. And just to say that earlier this year, in part of the division I represent, Sandridge Parish, they got their neighbourhood plan approved, which is a planning document. It does have planning authority, and we did manage to include in that restrictions on fast food outlets. We have, obviously, it's only just been approved, and there hasn't yet been an application go up, so we don't know how effective they'll be. But we've tried to limit the number of fast food outlets in a local parade of stores and how close together they are, so as to spread them out a bit more. So, you know, there are levers there already that, you know, we should be looking to use. Looking at the food poverty needs assessment, and I'm very glad to see that we're talking about leadership on this. And I think it's very important that there is some leadership, and coming from the county council is as good as places anyway. But then it goes on to develop a food poverty action plan, aims and objectives to address the root causes of food poverty. I think we'd just like to understand what the project sees as being the root causes of food poverty.
Who wants to take that? Tizzy?
I can start, I guess, looking through the food poverty needs assessment, when we're talking about the risk factors for food poverty. I mean, the biggest one that it talks about is poverty itself, you know, and the issues around kind of low income and that kind of thing. So those are obviously going to be, you can't, I guess, separate them. And when you're talking about the root causes, I think the real point of that is, obviously, you know, there's stuff that provides emergency food aid, and that's really important, and you need to be able to ensure that they're providing a sufficient service and that kind of thing. But really, it's about looking at kind of why people get into the situation where they need emergency food aid and how we can prevent that happening. So yeah, things like looking at the groups that are at highest risks and why that may be, and you know, when we think about things like the pandemic and the impact that may have had, that's having on employment, and particular groups that we know have been, you know, disproportionately impacted by that. So how we kind of work with those different groups and stop them getting to the point where they need emergency food aid. And that's why it works very well with the Building Life Chances, because that whole group is looking at different areas. So, you know, like Victoria said, things like employment, things like working with kind of the groups of highest need, to think about a more preventative approach. And that action plan will look in much more detail. So this is obviously a broad overview looking at so many different risk factors. I mean, there's things around mental health in there that you'll see that's can be a major barrier to employment, and therefore a kind of a contributing factor to food poverty. And yeah, there's, I guess, a lot of information about the risk factors. So it's about looking at those risk factors and trying to stop people getting to the point where they need emergency food aid, and also about more holistic approach. So if people are attending food banks, how can we make sure that they're getting all the support they need, and that food banks are then able to then refer them on to other services and identify, you know, other needs, and make sure that providing something that's holistic and not just dealing with, you know, providing that emergency food. So yeah, so there's kind of a lot, I think, to think about when we're thinking about the causes of food poverty, but it's about how we kind of address them and work within the Building Life Chances to make sure that they're being addressed at that earlier stage.
Thank you. Does that answer your question, John?
Yes, thank you. I think it stresses the point that whilst in the report it talks about the various groups like younger people, people with living disabilities, BAME, single parent households, etc. Various groups. The root cause of it is poverty, and that is what we need to be addressing. And undoubtedly, the recent cut in universal credit and things like that cannot have helped matters. And I think it's a shame that we didn't get support at the full council meeting the other week to write and say something to the government about it. Food poverty is caused by poverty. We should be doing more than we are.
Thank you, John. So thank you. I look forward to you coming back in due course with an update on this, Tizzy and Victoria. Thank you. And members, we are asked to note and comment upon the content of this report, and in particular on the Director of the Public Health's proposed direction of action on food poverty. And if I could ask you just to put your agreement or otherwise in the chat box, please. Just waiting for everybody to put that in. That must be nearly everybody. Yes, that item is noted. Thank you, Tizzy. Thank you, Victoria. Just looking at the time, it's 11:20, so it's probably quite timely before we go on to the next item. I'm going to propose we take a 10-minute break and return at 11:30. That's okay, members. So we'll see everybody back at 11:30. Thank you. Okay, welcome back everybody to the Public Health and Community Safety panel meeting. We've just had a short break and we're now resuming with agenda item 6, which is an update on the provision of services for people with long COVID in Hertfordshire. And I'm delighted that we're joined today by Dr. Sam Williamson, the Associate Medical Director of Hertfordshire and West Essex Integrated Care System. Try saying that quickly, ICS. Welcome, Sam. Thank you very much for joining us this morning, and I'm happy to hand over to you.
And thank you, Chair, and thanks for the panel for inviting me along.
Sam, can you just either turn up your volume or speak in a bit? You're just a little bit quiet. Yes, that's better.
Okay,
thank
apologies for that. Just saying thank you for inviting me, and thanks for the invite for coming to speak today. My name's Sam Williamson. Yes, as you mentioned, Chair, I'm a consultant in public health and Associate Medical Director across Hertfordshire and West Essex Integrated Care System. And today come to talk to the panel about long COVID and the provision of services across Hertfordshire for long COVID, for people who are suffering from long COVID. Really wanted to quickly touch on what long COVID is, and then secondly to describe some of the services we've got in place, as well as some of the steps that we're taking forward to improve those services and improve that offer to people who are experiencing and suffering from the effects of COVID beyond that acute illness. So the report's been shared with the panel, and hopefully the panel have had an opportunity to read it. Long COVID covers two components, which is firstly that ongoing symptomatic COVID-19 period, which is described as that period between 4 and 12 weeks following an initial infection. And also the post-COVID syndrome, which is the period after 12 weeks when patients or people continue to experience symptoms. And those symptoms are often symptoms such as fatigue, respiratory symptoms, and also loss of concentration, often which is described by people who suffer from it as brain fog, and is quite a common term that's used within the management of long COVID. And so it's obviously it's a new symptom, a new set of symptoms, a new condition that's been described as a result of the pandemic, and is impacting significantly on people, as a lot of the panel will have read within the media. The paper describes the sort of extent of the effect that it has, both nationally and also within Hertfordshire. And at the time of writing the paper, data from September showed that approximately over 20,000 people within Hertfordshire are likely to be experiencing long COVID. Now that does comprise both of those components, that ongoing symptomatic group, as well as there's people with that post-COVID syndrome. But obviously 20,000 people is a significant volume of people who are continuing to experience symptoms after that acute spell. So what are we doing to support people with long COVID? There are a number of services in place, and broadly speaking, they do cover both primary care and then specialist services. And primary care have been working we've been working with primary care firstly to support them to understand the condition, but also to recognise when people have ongoing symptoms, and recognising that as an impact of the COVID infection. To offer support and signpost them to information and advice, as well as to make the referrals into the specialist services. They also initiate some of those initial investigations to exclude anything underlying that needs to be managed and treated more medically. And then for the management of post-COVID and for people who need it at an earlier stage, i.e. in that 4 to 12 week period, we have set up our long COVID services within the county, and broadly speaking, they fit under the two geographic footprints of the clinical commissioning group. So that's Herts Valleys and Eastern North Hertfordshire. The services are broadly comparable, but are adapted or reflect the local service provision more broadly. And really, one of the things that I want to emphasise is that these services were set up very much at pace during the pandemic, and really one of the success stories that we've had is to get those services up and running to manage and treat a brand new condition at a rapid pace. And that's actually quite well reflected by when you look at the volume of referrals that we've seen coming into those services. Hertfordshire and West Essex has actually had some of the highest has had the highest number of referrals into its services compared to all of the other areas within our East of England region. And that really shows that not only have we had that service in place, but we've really improved the access into those services, which is a really great success story. The other thing which I wanted to highlight was that those services, essentially what we're doing is we're trying to plug in these patients into our existing therapy services. So that would be physiotherapy, pulmonary rehab, rehabilitation, and other services such as the occupational therapists, etc., etc. And so what we're wanting to do now, we've had some additional funding come through from NHS England, and we're using that to really bolster those services and focus on increasing the capacity. Recognise that NHS is under significant stress, and there is a challenge around workforce, and so getting patients and people who are needing some of these specific services, getting the staff in place is challenging, and we are continuing to work to increase that capacity, and that is one of the areas that we are continuing to work on going forwards. And that will help us to manage some of those onward referral to treatment. The last thing which I did want to touch on was ongoing work that we're doing to maximise the opportunities beyond the NHS, and to start to look at how those services integrate and work alongside the community services, the charitable and voluntary sector, and other commissioned services from the county council. And I know that Sarah, who I believe is also on the call, may want to add some additional content or comments to that, but we have some of those ties. They are there in existence, and really now what we're trying to do is build some of those links and those really maximize that opportunity and potential. And lastly, if I can, I just wanted to highlight an article that some may have seen in the Times from last week. It was a really quite a poignant piece that was written by a sufferer of long COVID, who described really actually how debilitating it was, but also within that article highlighted actually one of our local services and how well that is working, and how the approach that is being taken within Hertfordshire, that multidisciplinary approach, factoring in all of those different needs of the individual and getting them assessed and managed by that multidisciplinary team, is actually being seen as an exemplar nationally. So at that point, I will pause and open up. I think Sarah may want to add some more information.
Okay, thank you very much, Sam. And yes, welcome, Sarah Perman. One of the joys or frustrations of online meetings is you don't always get to see on the screen who's here. And I should have mentioned we also have the Director of Public Health for Hertfordshire, Jim Mcmanus, on this call this morning, who I know will be speaking in a few minutes. But Sarah, yeah, did you want to come in now before we go to members' questions?
Thank you. Just briefly, so I have been working with a network of voluntary sector organisations and council colleagues to, as Sam said, identify better what the non-clinical needs are of adults with long COVID, and see if we've got appropriate support in place. I chaired a meeting this week which was very constructive, and the areas that we're looking at are very broadly how we can support people to get back to normal, or as far as normal as possible, their lives, and also support them to get back to work. There were a number of areas that we discussed, but I'll just very briefly mention three of them. The first is around employers, and there is very much a need to educate employers on long COVID so that they can understand the people in their workplaces who are returning to work and the sort of support that they need. And we have heard from clinical colleagues about the risks of patients' recovery being impeded if they are rushed back to work without appropriate support. So one of the actions that I'm taking away from that meeting with public health colleagues and the district and borough councils and employer organisations is to think about what that education and awareness programme looks like for appropriate vocational rehabilitation. The second area is around voluntary sector help. So there are already good links into council services and also into Hearts Help, supporting people with long COVID with areas like shopping, Meals on Wheels, etc. But we identified at the meeting ways that that support could be stepped up and ways in which we could link in better with the clinical pathway to feed back to people who are in the pathway managing patients on those broader support needs of people that we're seeing through the council and voluntary sector services as well. And then the final area was on physical activity. So you'll understand, I'm sure, councillors, that because of the complexity of people's experiences of long COVID and the fact that they have ongoing and persistent symptoms, they need very bespoke physical activity plans. And we have already heard that Hertfordshire Sports Partnership is supporting people with long COVID. They have had a programme approved where they train up fitness instructors to understand the condition and personalise treatment plans for people with long COVID. And they do that quite carefully to make sure that they are appropriate programmes which are informed by all the clinical advice about long COVID. There is the potential for scaling up that provision as well. So that was another area that we identified at the meeting for a dedicated piece of work around physical activity programmes. There are other areas as well, but it was a constructive meeting and it's a network of organisations that I think will continue to meet to consider the broader non-clinical needs of people with the condition.
Thank you, Sarah. And actually, that's a really important point, isn't it? It's not just about the clinical needs. It is absolutely recognising that the non-clinical have as much value in patient recovery. And just a few questions before I open out, and I know Sunny is waiting to come in. So really pleased to hear the three streams there that you mentioned. So one is employers. Looking at the figures, you know, we can see that the largest bulk of people with long COVID is, not surprisingly, in the working age population. So obviously that will have a key impact. Voluntary sector, we have some great organisations around the country, or county, and the country. So it would be absolutely, it would be a mistake not to work with them and to build on what they offer. And I suppose thinking about the physical activity, really pleased to hear about the Hearts Sports Partnership project. And I suppose, is there currently a pathway for clinicians to refer into our leisure services? How can, specifically looking at long COVID patients, how are they being directed to leisure services where appropriate?
Shall I just come back on that? So there is a pathway to refer into this tailored provision that's being offered by Hearts Sports Partnership. At the moment, clinicians are not referring patients into leisure services because they want to make sure that the people they're referring them to really understand the complexity of the condition and don't inappropriately include patients in sort of generalised physical activity provision, because it does need to be highly personalised. But that is a link that we need to make. So that's where there is, I think, the need to do some work with leisure centres, with other services that are running physical activity programmes, and use the staffing and resources that are there to make sure that we can offer provision which is tailored for people with long COVID through that approach.
Okay, thank you, Sarah. I do have one other question, and then Sunny, I will bring you in. Sam, question for you about the funding, because I know, and it may well be that members are picking this up. So I can see from the report, funding is guaranteed until March 2022, but by the very name of long COVID, we expect it will, the symptoms of long COVID will be extending far beyond March 2022. So is there a plan to extend the funding?
So we have actually just in the last week or so had an announcement from NHS England about securing funding for the next financial year, which is fantastic news. So that will ensure that we can maintain our post-COVID service through 22-23. Sorry if I got my years right. Yes, that's right. Yeah. That's really positive news. It is something which we keep playing back to NHS England about, that security of funding on an ongoing basis as one of the constraints of keeping that service going. We do, and NHS England do recognise that there is going to be an ongoing need for a long COVID service. You've mentioned it in one of your questions previously about the complexity of the people who have long COVID, and there are a cohort of people who do have an ongoing need for a prolonged period of time. And so the sheer nature of this is that it goes well beyond that acute spell. And so we do need to have a service that is firstly able to support people on an ongoing basis. And actually one of the things that we're trying to take forward now is that longer term planning, not only about the services, but also about how we support patients and people who have very prolonged symptoms, and looking at things from a reablement and ongoing support basis.
Okay, thank you, Sam. Sunny.
Thank you, Chair. As you imagine, I've got a number of questions, so if you feel if I've overstepped my numbers of questions, do let me know.
Don't worry.
Sarah, Sam, thank you very much for the presentation, and I've had a really good read of the report. One thing that I wanted to highlight was quite impressive was in 4.27, assessment time, which I think the NHS guidelines or NICE guidelines are 6 weeks. We're managing to do them between 1 and 2 weeks in September. And this is on the background of, from what I understand, a very high number of referrals. Is that because we've recruited more, or because our assessment tool is much more effective?
Yeah, I'm happy to take that. So yes, we are performing very well. One week in the East and North Herts area, and 1 to 2 weeks in Herts Valleys. I would say that there are a number of factors that are influencing that. Firstly, we have had a service in place that has. So the guidance, the NICE guidance, National Institute for Clinical Excellence guidance on long COVID was announced and published in the summer of this year. We've actually had a compliant service with that for over a year. So you can imagine that just the sheer nature of having that service up and running for a significant period of time, all of those processes are well oiled and slick, and we have fantastic individuals who are dedicated as people who can assess individual needs and also provide that coordination function on an ongoing basis. So I'd say that's been a really key part of being able to manage that caseload. We've also done an awful lot of work with clinicians, both primary care clinicians and secondary care clinicians, to support patients and make sure that those patients are being managed prior to referral in. And so that is also supporting that wait time. And I guess the last element of that is also having a GP embedded within the services as well. So I think there are multiple factors that have helped, and I think just having that service up and running for a long time has really kind of helped with that process, keeping that waiting list time.
Yeah. Another question. I was looking at your flowchart, and the mention is of the screening tool. Would it be possible, perhaps because I mentioned it's quite a detailed screening tool, if that can kind of be shared? The only reason I was thinking about that is I work in a hospital, and over the years, I've found that screening tools were initially come in with a good idea, but end up sort of trying to prevent people coming to hospital and putting everything into community or primary care. And especially with long COVID, where, as you mentioned, there's a multitude of symptoms. Foggy brain and how that's assessed versus someone with shortness of breath. You can imagine someone with shortness of breath is like, okay, I think that can go to hospital. Foggy brain, oh, I'm not really sure, and then manage that in the community, when both of them are kind of, I wouldn't say just as difficult for the patient, but can have similar-ish problems with them. So I just wanted to know if that could be shared and have a kind of an idea of what that screening tool is.
Yeah, so again, very happy to answer that question. Screening tool may be somewhat of a misnomer on that. It isn't like it isn't there as a sort of sieve to try and say, oh, we don't need to see these individuals. It's very much there as an assessment tool, probably is a better way to describe it, to actually understand the individual's needs across a range of different areas. So it's there to support with the assessment rather than to sort of say, oh, you don't meet the threshold for that, we won't refer you in. So it's not necessarily seen as a screening in the same sense as a screening for a condition or screening for onward referral. It's more there to really try and understand an individual's baseline and where they are at from a functional capability, as well as those ongoing needs. I would be happy to share it. It is something which has been developed, and again, we've supported with that, or our providers have supported with the development of it. It is a standardized tool, which I would be more than willing to share. It is very comprehensive and goes into a huge amount of detail, and it really is there to guide some of that initial assessment.
Okay, couple of more questions, Chair, but of course, let me know if rather just put.
I will. Go for it. Go for the next one.
I was the other thing I looked at was section 4.23, which is the outcome measures. What I was, maybe it's the way I read it, I'm not sure, but are you basically saying that obviously you have the assessment? This is the last bullet point on 4.23. You have point of assessment, 3 months, 6 months, 12-month follow-up. And then you look to discharge after 12 months. Have I interpreted that wrong, or is it more to it than that?
Yeah, so sorry, yes, that degree of ambiguity there. So those are the assessment points. An individual will be discharged from the service when it is deemed appropriate. But what we want to do is we want to gather that information at those time points to understand where their quality of life is and what their functional scores look like. So slightly disassociate the time points for data collection from the point of discharge. The patients, sorry, I refer to them as patients, obviously they're patients whilst they're in the service. These individuals will be discharged from the service at the point whereby it is deemed appropriate. And if that links into one of those points in time where we would want to be capturing information, then obviously that serves as a useful time to gather that information. But we aren't holding on to individuals all the way through till that 12-month time point. It's many will be discharged earlier.
Brilliant. Another question I wanted to ask was, it seems that, and this is in I can see how this paper very similar to what NICE is saying, but essentially I think what we're trying to do is we're trying to get patients with long COVID, assess which of their systemic functional needs need to be addressed, and then they feed into that specialist service, so chronic fatigue, pulmonary, respiratory, physiotherapy. Do you anticipate that as this matures over the next few years, and once the ICSs come in, that we won't necessarily have a long COVID pathway as such, and more a sort of an early onset distribution of patients? Or do you anticipate that long COVID specialization with MDT will probably continue and mature more? Or is it very difficult to say at this stage?
I think it's very difficult to say. I think we are at the start of that discussion around what things will look like in that long term, and obviously it all depends on how the pandemic plays out. Clearly, this has started to shine a light on that that post-viral syndrome suite of symptoms and needs within groups of people. I think it probably is a little bit too early for me to answer that. But what I can answer is, you mentioned that obviously this is an assessment service that then plugs individuals into existing services, and that is a very conscious decision that we've gone down. We did not want to set up whole parallel services, whole parallel streams that under, as I mentioned earlier, at a time when we are very challenged with workforce, as I'm sure you are aware, we wouldn't want to sort of create siloed working. And so whatever it looks like going forward, we want to really harness and capitalize the existing service and bolster those existing services. I think there will always be a need for that multidisciplinary approach in whatever format that takes.
Brilliant. Thank you very much. And you please know I have no more questions.
Thank you, Sunny, and we're always grateful for your input, because you are a surgeon after all. So thank you. We're very grateful. Ron, would you like to go next?
Thank you, Chair. I've got a couple of points. First of all, I notice in paragraph 414 on page 37 that it says that the enhanced service is not mandatory for GPs to provide. But first of all, so could you tell us if there are any Hertfordshire GPs not involved in the enhanced service at the moment? And if there are, what steps are being taken to ensure that the patient journey is made as simple and as straightforward as possible? So that's the first one, and I'll come back to the second in a minute.
So I think I can pretty much with 100% confidence say that every practice in Hertfordshire has signed up to that enhanced service.
Yeah.
And if I can just very quickly give you some detail about what that enhanced service is, it's to ensure that the practices are aware of long COVID and understand the condition, are aware of the local pathways, and are accurately recording and referring individuals who are identified as having long COVID. So really, the whole focus of that enhanced service is to increase awareness, knowledge, and appropriate management of patients who are presenting with long COVID to practices.
Yeah, we've come a long way since social prescribing was first started by some doctors in the East End of London, haven't we? If we can move on. I think also, given the fact that the CCGs are going to be assimilated into the ICS at some point this year, on a far shorter timescale than taken to create them, I wonder, would it be possible that we could perhaps, Chair, have an update at each panel of any aspects of that assimilation which may affect our residents? Because as we proceed, it would be helpful if we on this panel knew what was going on in terms of the assimilation. Because I've been involved in some transfers of responsibilities and staffing over the years, and they are very complex and take some time. And so I think the timescale on this one is quite tight. So I would like to ensure that at the end of it, the patient is always at the forefront rather than the staff and who gets what chair in what office.
Okay, thank you, Ron. I can see Sarah's got her hand up. So do you want to come in on that, Sarah?
Yes, thank you for that, Councillor. We are working very closely with the existing CCGs and the ICS over that transition, and we can agree a way of updating you on the development of the ICS and of any key changes to pathways and risks. I think we also need to be mindful of the Health and Wellbeing Board and updates that are being taken to that. So probably a little bit of work that needs to go on, led by myself and Sam in the background to agree what would be the best way of making that work efficiently across committees, if that's okay.
Yeah, I don't want to multiply things or have duplication, but at the same time, given the recent government changes to the public health national framework, it does seem to me that we're in danger of losing sight of what we're trying to achieve in all this while all this reorganisation is going on.
No, that's point well made, Ron, and absolutely, we don't want to duplicate where reports and updates are going. So Sarah, if you're happy to take that away and liaise with Sam and see how best to keep members updated, that would be really useful.
Cheers.
Thank you. I don't see any other hands up at the moment. There were just a few points I wanted to come back on then, if I can. I'd like it noted that we're really pleased to see that that every GP practice has signed up to the enhanced service, because that was something I was going to pick up on. I notice in the report there are 2 different pathways, one for the east and north, one for the west, and there would be a natural concern, and especially if all GP practices hadn't signed up, that actually there might be a difference in outcomes. I'm just wondering if that still might be an issue, and whether or not we need to look at how we could, I suppose, review and monitor the outcomes. And I don't know, Jim, if you're able to come in on that. Is that something we could look to do?
We could, Chair. I mean, we could take it away and just looking at Sarah and Sam and work out how we do that, and then come back to you in a briefing with a proposal for how we monitor the outcomes. Would that be the quickest way of resolving that?
With agreement with Sam and Sarah, if that would be workable, I think that would be useful, certainly to have coming back.
I mean, I suspect the national surveillance of outcomes on long COVID is only just starting, but certainly Sam and Sarah have worked closely with our data team on this, so very happy to take it offline and buy my 2 colleagues coffee for the extra work I've just landed on that.
No, thank you. I think it's about ensuring that we have, not necessarily equal pathways, but we are achieving the best outcomes for all residents across the 2 pathways, bearing in mind they may be slightly different. That for me, I think, is an important consideration. So thank you. Yes, Jim, I will take you up on that offer. Thank you. And then Sam, would you be able to bring us, and Sarah, come back and bring a further update maybe in 6 months? Would that be too soon? Just to update us on how things are progressing, and especially in terms of numbers.
So I would suggest that yes, after the start of the new financial year and the emergence of an ICS ICB, maybe probably sometime in late spring, early summer, maybe a good time to come back, just because I can imagine that things may be rather busy over March, April, May time.
No, absolutely, that's fine. Just before you go, do you have, looking at the graphs that you provided, and I know it's broken down at age, at referral received, if you don't have the data to hand, that's absolutely fine. I'm interested to know the gender then breakdown, the male-female ratio of those figures. I know you've given the actual figure of the age ranges, because I know I've been reading something recently. There was an article in the press, and it was about women in their 50s and how the symptoms of long COVID could actually be mimicking symptoms of menopause, and whether there's a correlation, and actually whether something like a hormone replacement therapy could actually treat some of those symptoms. That's something I'm interested in on a personal level, and I think just would like a little bit more information around that, just to see if there's a correlation.
So I don't have that information to hand right now. Okay. I'm sure we would be able to provide that breakdown by age and gender, and certainly I can ask that question to see if we can cut the data in that way.
Yeah, thank you.
That does add the extra complexity of then being able to describe what the symptoms that those individuals are experiencing, which I don't think we're going to be able to get down to that level of granularity. However, I could certainly provide that initial level of detail.
Okay, thank you very much. Members, any other questions or comments? No, I don't see any other hands up. Thank you. Thank you very much, Sam. Thank you for bringing this report and update, and Sarah. very grateful, and I'm just looking at my document. So the panel is asked to note the current provision of long COVID services in Hertfordshire and to note and comment on plans for further integration of NHS long COVID commission services with Hertfordshire County Council commission services, as well as further integration of social and voluntary sector support for patients with long COVID. And if I could ask you just to put your answers in the chat box, please, if you're happy to note this. Just, I think that's nearly everybody. Just waiting for confirmation. And we have confirmation that item has been noted. So thank you very much. Thank you, Sam. Thank you, Sarah. Moving on to item 7, and that's a COVID update report. Delighted to have Jim Mcmanus, Director of Public Health, with us. Over to you, Jim.
Well, thank you, Chair. I've got some slides which I won't go through all of, and I'll go fairly quickly. And actually, it would help if I managed to share the right screen, really, wouldn't it? And very happy to take any questions, and Carly will be sending these slides out and putting them on the website as a public document. So I'll rattle through fairly quickly if that's okay. People may have seen this graph from the Financial Times from John Byrne Murdoch, who's also a fellow at the LSE, showing the black dotted line on the left-hand graph, COVID cases in the UK falling, what looks like a significant fall for all ages. And indeed, there has been a fall. But actually, if you look in the middle graph, the black line shows intensive care unit bed admissions have dipped and then gone back up again. So the key point there is actually all age admission rates are not a good indicator of the progress of the pandemic for hospital, given the sheer number of variables. And indeed, if you look at Hertfordshire, which is the purple line there, we're not falling that much. We're actually more or less plateauing. We are still seeing cases significantly higher than they have been for some time and keeping going in numbers. And the purple line there is Hertfordshire, mirrors fairly much the east of England and is now slightly higher than the east of England, which is the green line. So we can see that the England pattern is not the same as either the east of England pattern or the Hertfordshire pattern for a number of reasons, one of which is we mimic London and follow London. So overall case numbers aren't a good indication of transmission dynamics. There are multiple patterns at different levels across the region and inside Hertfordshire. The conclusion that cases falling overall is actually inaccurate when you look at the detail. And the contention that we have reached herd immunity, either in the population in general or in schools, is simply not supported by the data or by any calculations of what might be our RT or R0 for these purposes. If you look at our case rates across the east of England, you'll see actually that we're still above 250 per 100,000 right across the region. And if you look at the change, actually, although Hertfordshire has had, some reductions in some areas, one bit of Hertfordshire has seen an increase, and other parts of the region are really under 10% of change. So it is not appropriate to conclude that we have reached an overall substantial decline in cases. It could go back up again. And in fact, if you look at this graph, you can see that although it is much lower than either of the two red lines at the top, which are the two peaks, hospital admissions have started to creep back up again and to rise, and the 7-day average for Hertfordshire has also gone up. The orange is West Herts, the blue is East and North Herts, and the grey is where the data team haven't yet differentiated the trust. You can see also that mechanical ventilation bed use has also risen from almost no use between May and the middle of July. It has actually gone up, and the average is going up. So the idea that our case numbers are falling is simply not borne out by the data, nor the pattern of the NHS use. It may be lower compared to the peaks, but actually NHS hospitals are under multiple sets of pressure from COVID and non-COVID. And so this is not coming against the background where the only thing that is being treated in hospital is COVID. It is creating significant pressure. A closer look at mechanical ventilation, you can see actually that having dipped a bit into October, it has now gone back up again. So the virus is still causing people to be hospitalised despite the great benefit of vaccination. And we are not out of it yet. Now, if you look at the case rates, this is the case rate for the top line is a 12 to 16-year-old population, and the bottom line is the 0 to 11 population. And up to the 4th of November, actually, you can see the impact of half term there has meant there's a large drop in cases. But it's from a very high line of over 1,800 cases, and we're still actually, ignore the last data point, but we're still then above 900 cases per 100,000, which is very high indeed, which meant the virus still has a high pool of people to pass infection on. And in St Albans, like one or two other areas in Hertfordshire, it was actually much, much higher. And although has come down, is still higher than the rest of the county. But if you look at other age groups in Hertfordshire, actually they were still rising up until the 4th of November. And while there's been a bit of a decline, that decline could very easily go up again. And you could see that all the other age groups, and I've picked out the 25 age groups up to 80, and rather than just pick 60 plus, I've broken the 60 plus into 60 to 69, 70 to 79, and 80 and over. And you can see that most of them had an increase. That's something we want to avoid because it means there is a higher risk of hospitalisation and serious illness in that population. St Albans, a similar pattern. Over the last 21 days, as we can see, the over 60s case rate has risen. And although it may seem to have plateaued, we don't want it to rise further. We want it to come down. So we have to do something about reducing transmission in the community. You can see that the over 60 hospital admissions have been rising over the last 21 days, but thankfully care home cases have actually been falling again, which is good news. That means that these infections are by and large passed on and received in the community, would be my suggestion. Acute hospital staff absences from COVID have started to rise again, having been lower. They're nothing like as high as the peak, but they are rising, and that puts additional pressure on the NHS. And we're also seeing absences in other public services go up again. And our vaccine uptake in the 12 to 15-year-old age group is about 44% at the time of taking this graph. So we don't have full coverage out. And if you have an outbreak in a school, you can't vaccinate children who are infected for 4 weeks afterwards. So although we are doing reasonably well, we do need to do better, and we are working on that, which is why vaccination for 12 to 15-year-olds has been opened to the national booking system as well. We do well on vaccine overall, and I'll come back to that, but we do have more work to do. Now, you may remember me saying during most of the pandemic that we want positivity to be below 5%. Well, before half term, it was 30% in the 12 to 16 population, and it has fallen to about 25%. It was 22% in the 0 to 11 population and has fallen. And you can see in almost every population except those over 80, it is over the 5% where we want it to be, which is a clear sign that although the pace of the infection may be going into decline, there is enough positivity around so that we can still have a significant series of outbreaks moving around the county across all ages. And that presents a substantial challenge to us for winter. Education and leisure settings remain common sources of exposure. And you can see actually that during half-term week, the kind of leisure settings went up because a lot of people were using leisure settings. And although education settings have gone down significantly in terms of places people who became infected were at the same time or around the same time the window of exposure, you can see actually they still account for about half of exposures. So this virus has not run its course, nor have we reached herd immunity in schools or anything like it. And indeed, nor have we seen an end to infection circulating. Our testing rate remains high. In fact, it's gone up. So it remains, well over 4,000 tests per 100,000 population. That's a good sign because it means that people are taking PCR signs and we are picking up infection, but it's also a sign that people are finding reasons to take PCR tests, which means that the virus is clearly picking up infections. If you look at our wastewater analysis, which we do, and I've just taken one of the wastewater sources, you can see actually that in terms of gene copies per litre, the virus is still being found in wastewater. And if anything, the concentrations, if you draw a line of best fit, are probably actually increasing rather than declining, or at the very least, they're staying stable. So this virus is still circulating quite widely and quite happily, and we are not at an endemic level of transmission. We are still in epidemic conditions. In the week beginning ending the 5th of November, there were 202 schools in Hertfordshire, including 55 secondaries, who had confirmed outbreaks of COVID. In the week ending the 12th, so far, we have 211 schools with confirmed outbreaks, with 58 secondary schools. So actually the numbers of outbreaks in schools have increased, not decreased. And if you look at the districts in the 5th of November, they were spread more or less across all districts, with East Herts and perhaps St Albans and Dacorum with slightly more numbers. Do stop me if I'm going too fast, but I want to give members plenty of time for questions. But you can see here actually that it's more or less spread right across the county, even although you still have those three areas predominate. The number of outbreaks in North Hertfordshire has gone up, for example, and in Three Rivers. So we are clearly seeing the virus still surging across the county. So there is no part of the county without an outbreak. Many schools had already introduced measures. Many employers are actually asking for advice still. Many employers and schools have seen local outbreaks. We are seeing obviously the county-wide ones. So we're still working with employers. Our advice to employers, our advice to leisure services, our advice and guidance to schools is still there. And we've taken what the best schools are doing and have applied these to our own local guidance. And the dedicated COVID team, both for employment and for venues and for schools, those teams are all still there and in place. In terms of non-school measures, we're continuing test and trace. You will have seen the new public campaigns work, including the Winter Health Guide recommending booster vaccine and flu vaccine, which was published yesterday. We're continuing our vaccine uptake work, and vaccine uptake continues to go well. I'm really pleased to announce that we have something like 96% coverage of 2 doses of vaccine for social care staff, for example. We're continuing the self-isolation support for people who need it. We've actually enhanced the testing availability for lateral flow tests, and 9 libraries have joined lateral flow test pickup sites in the recent week. Our business and workplace support for winter preparation continues, so we're continuing to advise them, and most recently we've had a series of webinars with the Chamber of Commerce. Our campaign for prevention, Play Your Part, and the vaccine campaign goes on. Our COVID event safety service continues. Free advice and guidance for all employers, hospitality and licensed premises, working with environmental health departments, without whom we really couldn't do our job, will continue. and all our public transport operators recommend face coverings. And in fact, you know, there is no doubt, given the evidence published both on the 9th of November by Public Health England and on the 22nd of October by government from SAGE, that face coverings in the right setting for the right population are a useful tool. It's not that you wear them in all cases, it's that you be judicious about when to wear them. So crowded public transport, for example, is more important than, you know, if you're in an empty building or you are in an appropriate meeting. Just a reminder that in March, the Department for Education itself published a blog for parents about face coverings, and members interested may read that here. So to turn to school measures, we have taken a number of measures about ventilation, about enhanced testing, about seeking to increase vaccine coverage, and a number of other measures, including the recommendation of face coverings in certain settings, which is obviously down to case-by-case advice between the school and the COVID advice team, not for primary school children, but for secondary school children and obviously for adults. The reasons for taking these measures, I would hope, are apparent from this presentation. The case rates in school-aged children in Hertfordshire were among the highest 20 in the country, and in some places just short of the highest 10 before half term. And while cases in some ages have dipped, they could easily rise again. The virus is still circulating widely. The positivity rate was as high as 1 in 3 children testing positive, and so the virus is still circulating and numbers could rise again. Our over 60s rates are increasing, and we know from previous experience that rises in infections of younger age groups can and do spread into older age groups. Our hospital admissions are increasing, and we have clear evidence of transmission from infected children into the rest of the community and older adults, and vice versa. It is not that schools are the source of infection, it is that the infection is widespread in the community and is using every opportunity. So we mustn't blame any individual setting. This is just what viruses do. So we have a significant cohort of young people with very high positivity and high case rates. There's clear evidence of spread. The Joint Schools team and the Joint Schools Governance Group, which has head teachers as well as education and public health on it, are meeting regularly to kind of look at things we want to do. A number of schools had already introduced measures of their own initiative, and actually we took the best of what they feel they've advised. And as you will be aware, schools make their decisions with the advice and support of our team. All of the evidence is clear that a combination approach, what we might previously have called the Swiss cheese approach, works best in reducing the transmission of COVID. And that's defined as a number of measures, including ventilation, face coverings, testing, isolation, and a number of other measures too. So the updated Swiss cheese graph remains important. If you have symptoms, isolate, which is still required. Good hand hygiene and cough etiquette is still important, so you know, don't cough on people, cough into a tissue. Limit your time in crowded environments under current government guidelines. Regular testing and promoting ventilation and the uptake of the vaccine. So all of these measures are important. Good news to finish on. We have seen a massive decline in deaths. That sadly and tragically, people are still dying, as you can see, with COVID or from COVID. It is much fewer in number than the losses we have seen hitherto, and obviously we hope to kind of drive that down further. But that is welcome news. And we're also seeing that the level of vaccine uptake is very good. The lighter blue is the second dose, the darker blue is the first dose, and you can see actually that as our age groups go up, we are seeing much better vaccine uptake as we go up. We still have work to do with the 12 to 15 year age group and with the 16 to 17 year age group, but this on the whole should be encouraging news. And Chair, I'll stop there if I may, and perhaps stop sharing the slides so that people can ask questions.
Okay, thank you. Oh, there's a bit of feedback. Thank you very much, Jim. That was a really comprehensive update, and actually some really key public health messages in there as well for us all to take away and to share with our communities. Just a few things to pick up on before I bring members in, and I'm sure there'll be lots of questions. Really pleased to see that care home cases have plateaued, because I know that was one area for concern, and let's hope that remains stable. Is there a correlation between the increase in outbreaks and the vaccination rates? And sorry, I'm just thinking about the wider I know your last slide showed that actually the vaccination rates for the first and second doses were quite good and have come up significantly. I just wonder about the booster doses. We've heard in the media that, you know, perhaps the efficacy of the first and second doses are now beginning to wear off. And is there a correlation there?
I think it's a complex picture. So there is no doubt that the people being admitted to hospital still, there are a lot of people who are unvaccinated or only partially vaccinated from the dashboard, and we now have some fairly detailed data on that. There are people who have been double vaccinated who are admitted. They are mostly people who are older and have comorbidities and in whom there might be waning immunity, so it's important to get the booster. I think it's also perhaps important to say that if you've got a large, highly vaccinated population, just by dint of sheer numbers, the number of people double vaccinated going into hospital will go up anyway, and it doesn't mean that the vaccine is failing. And I'll quite happily send members a useful infographic on that if they want. But there is no doubt that we need to get the booster into the arms of the people who were vaccinated some time ago. It's probably also worth saying, Chair, that people talk about natural immunity. I don't recognise a phenomenon called natural immunity. There's infection-induced immunity and vaccine-induced immunity to this. So vaccine-induced immunity still seems to remain better than infection-induced immunity from the research that is being published here. So the key thing is to get as many boosters into as many arms as possible of people who are over 6 months. Was that clear, or did I?
No, thank you. Clear, absolutely. I'm just wondering if there's a bit more work to be done. So, for example, I know in Welwyn Hatfield, there's one location to go and get your booster jab, which for those who don't have transport, it's going to be quite difficult. So, you know, the first rollout of the vaccine programme was hugely successful. I think we would all agree. In fact, many of us were volunteering at some of the sites. This booster rollout is clearly different. And I suppose I'm concerned if residents are being prohibited from obtaining the vaccine boosters because of access issues. And so is there a bit of work that we can do there? Absolutely. I think the more we get the booster easier to get to people from walk-in centres and bookings, the better. And the joint vaccine cell will work on that. Yeah. Sorry, I was just to interrupt. Is there something we could do through, I don't know, through the Health and Wellbeing Board? Is there a bit of joint working that we could do? I don't know if that's something you could look at. I'm very happy to take that away. I mean, there remains money for local for district councils and for local members and for voluntary organisations to improve uptake in their areas. So I'm very happy to take that back to Health Protection Board, and indeed if any district council or councillor or voluntary organisation wanted to look at what they could do to take up vaccine uptake, we'd be happy to talk to them about how we could support and fund that and link them into the vaccine cell, because the £150,000 worth of grants we gave on vaccine uptake earlier this year have made a major difference, and doing that again on boosters would be really good. Okay, thank you. Before I bring members in, I've seen Alex Woodman, you've your hand up, Alex, the new Director for Community Protection and Interim Chief Fire Officer. Would you like to come in there, Alex?
Thank you, Chair. I just really wanted to follow up from what Jim was saying. As you're aware, with my other hat on as chairing our LRF, our Local Resilience Forum, Jim and I have been working very closely and reviewing with the current chair of our strategic coordination group, that's Jenna Telfer, who's one of the assistant chief constables. I just thought it was a moment just to touch on the fact of, as you'll all be aware, the SCG has been sitting throughout responding to this pandemic, but I think it's quite right that we review that. We met recently to review the role of the SCG and deemed that actually the requirement to keep this running through the winter period because of that potential, the systems failure. And I think what I just wanted to reiterate for you and the group was that, as Jim has said, public health messaging here, the role of the public, the role of the vaccination programme is so critical, but running in parallel and to support that, what we do have is our SCG Forum still stood up that brings together those key strategic partners. And I think to support the public health messaging, we've deemed that that is necessary to keep that running over the winter, and looking to the public again to make sure that what we don't do is see that surge in demand on systems, so we see that critical failure. So I think really assurance that that system and forum is still running, confidence from the system that the partnership approach is working, but critical underpinning of that is the role of public health messaging.
Okay, thank you for that, Alex. That's really useful. Okay, who have I got? Judy, you're first. You're on mute, Judy.
Probably a good thing, because I've gone all croaky again. I think it's sitting here not speaking for hours. It's very upsetting not speaking for hours, obviously, if you're me. I wasn't going to raise this. It's not why I put my hand up, but actually, any help that we can have in North Herts about boosting booster rates would be great, because I'm a boosted person, but I didn't find the process easy. I didn't find it easy to get accepted for a booster, and then I wasn't able to have it in my hometown. Now that's okay for me. I can zoom about in my car, but that's not all right for lots of other people. So I will come back to Jim on that if that's okay. What I actually put my hand up to ask about was the fact that I know that it didn't pass Jim's notice, that I got caught up in a fairly unpleasant Twitter spat this week with some people who thought I should be challenging the science of what we were being told by the director, and were a group of people who seemed to be particularly cross about advice to schools. And I wanted to ask Jim if he would like to give a caution to other members on this, because it's very easy to get caught up on social media and these things. But also, do we know what the size of this protest group is? What's driving them, for heaven's sake? And is anything being done to allay their fears? No, that wouldn't work. Whatever needs done.
Thank you, Judy. Jim, do you want to come back?
Yes, I think there's several things in there. I think on the booster, absolutely, I'd love to work with North Herts and get boosters up, and anything we can do. And as an open invitation for districts and voluntary organisations to come and talk to us about what they can do, and we can work with them in the NHS, because even things like community transport increase the uptake of boosters, as we found in Watford, for example. So open invite. Second, in terms of the schools issue, I think there is a view that face coverings in schools should not be used and should never be used, which runs, in my view, counter to the weight of evidence, including the evidence published on the 22nd of October on the consensus statement. Obviously, measures have to be used judiciously, and I think what we have in Hertfordshire is a situation where we have involved schools, we have representatives of schools on our steering group, we have regular meetings with head teachers, we have regular reviews of the science. Sarah Perman, who you will have seen earlier, for example, is one of the people involved in assessing the science on that, and we communicate regularly with the UK Health Security Agency. It remains the case that multiple measures, including in some circumstances face coverings, remain relevant and useful. I think there is a that's my reading of the science, and we will follow the science, and that is backed up by the evidence internationally and the evidence nationally. I think there is an issue about people saying that face coverings in children are detrimental, and I think there actually the evidence is actually much more mixed, because and I've spent quite a lot of time reviewing it recently. There are some who will say that face coverings reduce the recognition of emotion, and they have a polarizing effect on emotional recognition and facial recognition. But actually, there are studies, and there's one study done in Italy, which concluded, and I quote, "Despite the covering of the lower face, participants correctly recognize the facial expressions of emotions." So there is a difference here. What we've tried to do is be nuanced and recognize that while there are concerns that face coverings can disrupt education, it is a balancing of risk and harms. And the sweet spot to get to, if I might use that phrase, is using them when appropriate, when necessary, in certain conditions, and not when they're not necessary. And those are different from adults. It's different going into a meeting of a large group of doubly vaccinated adults who've been tested compared to a large group of largely unvaccinated children. They are two qualitatively and epidemiologically very different situations. There are ways that teachers can get round any downside of face coverings, and we're not recommending them for younger children. So we think we're taking a nuanced and case-by-case approach following the evidence. I think the challenge with this, of course, is that there are a number of people who will always disagree with that position. And I think what we have to do is go back to the science. In terms of the numbers of them, they may have a large following, but there are equal numbers of followers of other organisations. So if you look at Trish Greenhouse, who's just published papers, if you look at SAGE, if you look at people like Kit Yates, who's a mathematical biologist, they do exist. It's what I aspire to be next, to achieve a further level of deep sadness. And they are all saying actually the evidence is quite clear in support of face coverings. And I'm sorry you got caught up in that, Judy, but my advice would be, if parents are worried, they can go to the teacher in the school cell. There is a dedicated phone line and email for head teachers to contact. We will continue to follow what the science says and to do that in a way that has the most benefit for our children. The bottom line here is actually our aim is to keep children in education safely. Children who get long COVID suffer significantly. Children who are out of school for a long period suffer significantly. Actually, and we can't vaccinate if there's lots of infections. So I think that's the area of discussion, but it seems to have generated much more heat than light, I think. I'll stop there. I don't know if I made any sense at all there.
It made perfect sense, but would you like to advise other county councillors also to refer everybody back to you rather than getting embroiled?
I'd advise them to contact the school's COVID team.
Oh, all right.
The 7 day a week, because at the minute the individual stuff I'm dealing with at the minute is more about people having problems with boosters. Yes. But yes, I'm happy to speak to any county councillor who has any questions or issues at all in detail about any of this at any time, morning, noon or night. So if you have an issue, do please come and talk to me.
Yeah,
Brilliant.
Thank you, Jim.
Thank you very much.
Yeah, sorry to hear about that, Judy. That sounded like it was most unpleasant. I completely missed it. But of course, we know there is an issue with anti-vaxxers, although a relatively small issue. Yeah. And we're lucky to have Alex, I suppose, on the call as well. So, and obviously, I know the police are very aware of the situation. So it's something we are monitoring. But yes, good advice from Jim. Thank you. Does that answer your questions, Judy?
Yeah, absolutely.
Yeah,
I just wanted to highlight it. I'm not suffering personally, but I just wanted people to be aware.
Okay, thank you. Adrian.
Thank you, Fiona. Can I, just a quick point on masks, can I speak up for eye contact and the forehead and eyebrows? Lots of stuff going on there.
Which works so long as you're not wearing a hat as well as a mask.
And a fringe. Oh, sorry.
Well, yes, indeed. Jim, I really welcome the intelligent work to apply best practice across schools. And I see also on my emails this morning that we're now at least moderately curtailing opening hours in places like libraries. But I'm really worried that instead of the scary peak that we saw previously in this, we are now regularly seeing 200 plus deaths per day in the UK, a plane crash per day. And we need to add them up, because they don't come and go and now they're gone and we forget them. We need to add them up. And if you added them up and put them on a graph like that, then I think we might respond differently. My first question is, am I right that the excess deaths are now up and not insignificantly? Then to go on, effectively, we've got hundreds of planes flying in dense fog, because I think everyone is getting confused about what you are supposed to do and what you're not supposed to do, frankly. And I think if we were talking about the airline industry and we were saying there are hundreds of planes up there in a holding pattern, they're coming in one day at a time, the airline industry would say, well, we need to ground planes. So can I briefly speak up and say, can we promote the Swiss cheese glide more widely? I think it makes a lot of sense. I think it's a way that people might be able to get hold of. So I would strongly back that. And isn't it the case that with the vaccine, even with a successful rollout, is only 90 plus % effective? So even for those who are vaccinated and who have gone and got their booster, they're still not 100% safe. And I think there's a perception that if you're double vaxxed, then it's all good, which isn't quite the case. And I think we need to keep banging in that message. So effectively, we don't have real control of this virus. And we are right now going into winter, Christmas. We are asking for trouble if we don't prevail upon central government to take immediate action to reduce infections right down to levels where we can trace outbreaks.
So, Jim, do you want to come back on that? Obviously, there's a clear question around sharing information with us, which clearly you have done, but it's around the wider public, isn't it? So that everybody plays their part.
I'm very happy to do that. I think what Adrian, I think, neatly highlighted was we're going from massive peaks into significant enduring transmission that's just going on and on and on, and we'll continue to do that. And we're relying an awful lot on the vaccine. And actually, some people are relying too much on the vaccine because, as he says, it's never 100%. So I would just say I agree with his comments. Very happy to produce and publish whatever data he thinks would be right, would be useful, if that helps in terms of infection. But we are seeing significant levels of enduring infection, even though infections have fallen. And what we're not seeing is a big peak and then a complete drop to nothing. We're actually seeing a big peak, then a drop, but it's not going down still. It might do, but actually it is equally possible that it will go back up again. Hence the Swiss cheese approach is really important, not just vaccination, because people who are double vaccinated, as Adrian says, do get infected.
Yeah, and just a reminder to members, there will be an all-member COVID webinar, which everybody should have received invites for, which again will help just to share the information that we need to spread. Does that answer your question, Adrian? Thank you very much. Sunny next, please.
Thank you. Few points. Always surprised that Julie gets into a Twitter argument. I'm sure that's not the first time. The other thing was I've stopped engaging with people who don't believe in the science. I've done that not just in the last year, but before that. Unfortunately, we have one of our own, Andrew Wakefield, to blame for that thing. I just ignore it now because they're not going to listen to what you're going to say, and I've yet to be able to convince anybody about the science. So I just ignore them, to be honest. It's a quick question, a quick point on the deaths, actually, Jim, and I think you're right. Of course, you look at the national picture, and I can more on the local. But we were having a briefing about this, and I've got to say a lot of our ITU patients fall into the category of unvaccinated, huge comorbidities before they got it. And there seems to be some sort of indication that even though you're double vaxxed, the 6-month period may actually be too short. And when they were rechecked, the immunity levels were almost back to baseline. However, we were told, or I was told via a virology webinar for London, that there was a feeling that infection-induced immunity was better than vaccination-induced immunity. Was that because they were talking about different types of vaccines, like some are better than others? Or is there a slightly different thinking between virologists and public health?
I think there's it's quite interesting. There was a British Society of Immunology update on vaccines recently, and they were debating some similar things. And it would appear to be the case that you're right, in some people immunity wanes very quickly, both infection-induced and vaccine-induced immunity. Infection-induced immunity does have strong benefits, but would you want to go through the lottery of death and serious disease to come out the other end with infection-induced immunity if, depending on your age, you have a high risk of death? And I think that's the problem with this perception that infection-induced immunity is a great thing, because if you could infect people and induce immunity without having any serious side effects, well, you wouldn't need a vaccine at all. Unfortunately, people die, which is why you need a vaccine. So it seems to be the case that there are benefits from both, but both wane. Some vaccines provide better protection against variant than others. So it's not it's as ever, it's nuanced, and unfortunately the public debate doesn't allow either for the nuance or the complexity that, for example, Adrian and you are both raising. So the best messages we can give are, if you've been infected, well, you'll have some level of immunity, but actually take advice from your doctor on whether you should get a vaccine. If you haven't been infected, get the vaccine, because really, do you want to have even although if you're much younger, we can't predict who will die and who will not beneath about the age of 30 with real sensitivity, as you can see with young people. And I think the problem is people are assuming that the vaccine is a magic bullet, and it clearly isn't. And it's not perfect, but it's better than anything else we've got. So we are still fighting this pandemic with imperfect tools. I don't know if that answered your question.
No, I understand it. I mean, a lot of it is academic, because what they were saying is if you had got the infection and then had the vaccination, you were a lot better versus if you, and I think they were just looking at, like, if you get an infection but survive it, your immunity is better than if you, I think it was AstraZeneca, they were talking about them having that 2 booster, but then with a 6-month period. But yeah, like you say, there are nuances, and I just wanted to understand your point on that. A couple more things, if that's all right.
Yeah.
I saw the Swiss cheese. I love your Swiss cheese model, and I've actually used it quite a lot. But I saw a different version of it the other day, where the vaccination, because on your one, vaccination was the end point, but they'd pushed the vaccination further back. Is that an older one that I saw, or is there 2 schools of thought on that?
I think there are multiple versions, because you might remember earlier on in the year. So what Chris Whitty says is that with any major public health crisis, so HIV, TB, it is not. There's never been a single magic bullet. It's always been a combination of lots of little things that, added together, make the difference. And so there are as many models of Swiss cheese out there or diagrams as there are people. And I think the one with the vaccine further back is an older one that was done before it. So in a way, I'd put the vaccine front and centre, absolutely. but what I wouldn't do is rely on it as the total thing. So check the age on the image when you use it, because there's been about 100 iterations of it since the beginning of the pandemic.
Yeah.
Thank you.
And the last bit was on testing. Interestingly, I get PCR tested. Well, it used to be twice a week, and now they've said that actually you need to have it once every 2 weeks. And I think it's a decision made just within the hospital I work in. But the interesting thing was, like, we do test a lot, and I understand Germany is going through a bit of a fourth wave potentially, but their testing is significantly lower than us, almost by a factor of 100, I think. Do you, in your opinion, do you think the level of testing we're doing is okay, is like we should do, or should we be more discreet?
I think it depends on what kind of testing you want. So I use a lateral flow test before and after every meeting I go to and every event I go to, as one of the things. I think lateral flow tests are good enough as a screening tool to weed out some positive people and reduce the pool of infection. You wouldn't want to rely on them as a complete diagnostic tool, for example. So I'd encourage more lateral flow testing, which is a bit of a switch actually, because as you know, when I was still reading the early science, I wasn't convinced about LFTs in the early days, and as we know more, they're more of a useful tool. I think PCR testing really should be restricted to people with symptoms, and those particular situations where an early PCR test is really useful. So there's some early research about care homes that suggests that if we use, unfortunately, the PCR test takes too long to do this, but if you could get PCR test results within a couple of hours, you could use regular PCR testing in care homes, which would give you an early indication of the beginnings of an outbreak in a care home and actually do even more to prevent. So again, I think the testing strategy needs to be very nuanced. I think Germany's not testing enough. I think we're testing. I think we still need to go back and revisit our national testing strategy, if that makes sense.
That's perfect. And sorry, one last thing, Chair. Congratulations on being elected to the Association Directors of Public Health. I know I'm your biggest fan, Jim, so I'm always throwing you a flag.
Thank you for mentioning that, Sunny. Okay, I am conscious of time. However, John has very patiently been waiting. So, John.
I'll be very quick. I just wanted to emphasise two things. One, following up on what you, Fiona, and Judy said earlier, is I think there is a problem on the booster programme. When I got my vaccinations, there were lots of places doing it. You could walk in and do it. Now it is, you have to. There is one place in St Albans, effectively. The government can't complain about lack of people taking up the boosters when they don't make it easy to do so. And the second thing is on face coverings. End of October, I was in North Carolina, which is southern United States. You'd expect it all to be anti-vaxxers, etc. The counties and cities there have all mandated face coverings in shops, in restaurants, in cinemas and everything like that. And it is being followed. Come back here, go into Tesco's. Even the employees are barely wearing face masks, and probably 20% of the customers are. I think we really do need to revisit that in here. But that's me, as quick as I could be.
No, thank you, John. Thank you for both comments. And so, Jim, you're going to go away and on the vaccine programme, because I'm sure we do work closely with the NHS, but actually we know there's more that can be done to make it easier for people to have the boosters, and I think that's very important moving forward. Thank you, Jim. Very, very comprehensive, always interesting, and to hear the science behind the recommendations for what we should be doing, rather than getting our information off social media, which is a bit questionable. Panel, you are asked to note and comment upon the content of the Hertfordshire Local Outbreak Plan, COVID-19, report and presentation. Could you place your comments in the chat box, please? Just waiting to ensure everybody has agreed that or noted. Lovely. So that's been noted. Thank you very much, Jim. Moving on, I'm very conscious of time, panel, but lots of information to get through, and it's all very, very important to have the time to discuss. Item 8 is the Sports Grounds Safety Authority, the SGSA inspection report for 2021. I'm delighted to welcome the community safety team who have been waiting patiently. And so Andrew Butler, Assistant Director for Community Protection, you're very welcome.
Thanks, Chair. Good afternoon, and you'll be pleased to hear it will be a very quick update for me, but obviously happy to take your questions. So yes, this is an update on a recent audit of HCC carried out by the Sports Ground Safety Authority, SGSA, formerly known as the Football Licensing Authority, and they are effectively the government's expert body on all things sports grounds. You might have seen them in the news in the last week or so following the government's announcement around safe standing at football grounds, so quite topical at the moment. And they were set up really following the Taylor report, following on from the Hillsborough disaster, which recognised that there was fairly limited oversight of local authorities' work in this area. So they have a regulatory role really just to oversee local authorities' work. In Hertfordshire, this work is carried out by our regulatory services team within community protection. And our role really is to chair safety advisory groups for those grounds, to issue safety certificates, which includes setting the capacity for the venues. But we also carry out inspections and obviously enforce if we need to. Every 2 or 3 years, the SGSA come along and audit us. And they generally focus on what are known as our 2 designated sports grounds in the county. This is designated by the Secretary of State as needing a safety certificate. So that's Watford Football Club, obviously Premier League club, generally sort of attracting around 22,000 at full capacity every other weekend, and Stevenage in the 4th tier, who are obviously significantly less than that. So we also have a role in terms of other sports grounds, so also other events that happen in sports grounds. So as Jim will know, we had a series of music events at Stevenage Football Club over the summer, so we have a role in that. And we've had various sort of concerts at Watford Football Club over the years as well. But also we get involved in other events, such as we've had the British Masters in Hertfordshire. Of course, we had the canoe slalom back in 2012. As well as our big 2 grounds, we also put quite a lot of effort into working with our smaller clubs. So Boreham Wood currently top of the National League, so we're keeping an eye on that because, of course, if they get promoted, they'll move up into that top 4 tiers of professional leagues, and various others. St Albans, for example, were live on TV on Sunday with a full crowd on BBC. So we keep a close eye on what they're up to as well. A couple of final points to make. Obviously, sports grounds have been massively impacted by COVID over the last 18 months. So clearly, we've had to work very closely with environmental health colleagues, with Jim's team, just to make sure that spectators are as safe as they can be. In terms of the report itself, as you'll see, a very positive outcome for us as a local authority. We scored top marks in all 9 areas assessed. Which of course is really pleasing, but as I would expect, it's an area of work that we put a lot of priority to. We've seen various disasters at football grounds over the years, of course, and more recently the events in Texas, whilst not a sports ground, I think really emphasised the importance. So yeah, just one minor recommendation you'll see in the report, which is in the process of being actioned. So that's a very quick overview. Obviously happy to take any questions.
Okay, thank you very much, Andrew. And yeah, congratulations on achieving top in all 9 categories. That's credit to everybody who's been involved, and obviously, yeah, safety is hugely important. I was going to ask you about the pilot, the safe standing areas. How will that impact us? Bearing in mind we do have Watford Football Club. Are they involved in the pilot?
Yeah, so Watford are not one of the, I think it's 5 clubs that have been chosen for that pilot. Not aware of any plans to do that in the short term, but of course, I imagine they will, as we will, be keeping an eye on those trials with interest, and we'll wait and see if that comes to Watford, but not in the short term. Okay,
thank you. Right, I have some members waiting. So I think it's Sonny. I can see. Oh, was your hand up, Sonny? Was that a legacy hand?
Sorry, that was a legacy hand. I've taken it.
Okay, so John, please.
Just a couple of things. First of all, congratulations on the report. I seem to remember a similar one a few years ago, so you're obviously maintaining the standards. And No offence to you, Fiona, but it's a shame that Maurice isn't chairing today, because my second question was going to be that I hope the team will be talking to Hertsmere about security for when St Albans go to play away at Boreham Wood in a few weeks' time.
Absolutely, yeah, that's very topical. And those that haven't seen it, yes, the FA Cup has thrown up a local derby, so Boreham Wood at home to St Albans, which again will be live on TV. So as you'd imagine, we're very we're already in contact with Boreham Wood to understand what that looks like.
Good, glad to hear you'll be in touch. I'll be looking forward to watching St Albans win that game.
Yeah, what I would say is Boreham Wood are very used to hosting quite big crowds, because they do host Arsenal ladies, which of course over the years is increasingly attracting larger crowds. So we're pretty confident that will be something they can manage well.
Thank you, John. I will confess I'm not a football fan, so yes, Maurice would have been much better placed to respond to that. But no, duly noted. Thank you very much. Oh, Andrew, I don't see any other members with their hands up. Thank you very much for your patience and for presenting this report, and congratulations again on achieving this. And when will you bring? Did you say every 2 to 3 years it's reviewed?
Yeah, generally every 2 or 3 years we're audited, and traditionally we've brought an update to this panel after each audit.
Okay, thank you very much. So panel is asked to note the outcome of the audit carried out by the Sports Grounds Safety Authority in relation to the County Council's responsibilities under the Safety of Sports Grounds Act of 1975. And if you could comment in the comment section, the chat section, please, if you are happy to note this. I'm chuckling, somebody's written, noted, come on St Albans. So I'm sure Boreham Wood as well will be rooting.
I was not, Chair, commenting on your knowledge of football. It's more that Maurice, of course, is the leader, I believe, in Hertsmere.
Yes, no, I accept that. Okay, so that item is noted. Thank you very much, everybody. And moving on to item 9, we have 2 more items. Blue Light Collaboration Annual Report for 2020-21. Delighted to welcome Simon Toohill, the Assistant Chief Fire Officer. Good morning, or good afternoon, Simon. Welcome.
Good afternoon, Chair. Good afternoon, Councillor and colleagues. Thank you for inviting me along today. Chance to present the panel the CPD Blue Light Collaboration Report for 2020-21. The report highlights really the breadth and depth of activity that's taken place within Hertfordshire over the last 12 months between the 3 blue light services. The report specifically highlights the role of the Hertfordshire Emergency Service Collaboration Programme Board. That was introduced with the vision to coordinate the individual collaborative projects, achieving the vision of the strategic board, which is the Hertfordshire Emergency Service Board, which is attended by the leader of the council and the PCC, Mr. Lloyd. That programme board is in effect the engine room that drives project delivery in the county in relation to collaboration, and provides a coordinated approach to public safety, whilst we're ensuring that there are improvements in efficiency and effectiveness where we can identify them. I think my covering report in section 2.5 makes a reference to note the importance of the fact that collaboration and interagency work across the blue light services is deeply embedded. And actually, on almost all occasions, is regarded by partners as a business as usual effect, with the on the ground, on the boots colleagues working closely, every day with each other in a really joined up way. And then the other thing I think is probably fair to just reference quickly is around the impact of COVID-19 and the impact that's had on our joint working. There's been numerous examples, a couple of which I'll highlight maybe. As colleagues will know, Fire and Rescue have seconded firefighters to the East of England Ambulance Service to drive ambulances and they've asked for our help. And indeed, we still have some of our colleagues providing that service at the moment. Another example was the excellent work that Fire and Rescue CPD alongside other Blue Light colleagues, undertook for Operation Eagle in Broxbourne during the surge testing for the South African variant. And the numbers are excellent. We visited over 7,000 properties and delivered 6,800 PCR testing kit to those residents when it was required. So that was joint work between using fire service logistics, such as our dedicated command support unit, our firefighters, our volunteers, police support staff, and then of course HCC and health colleagues as well. So some really excellent work as a result of the pandemic. Just looking at the actual report, there's obviously a lot of snippets in there and details around some of the collaboration we've done. I thought maybe I'll just pick out two areas to just highlight to the panel. So the first one on page 5 is around the fire service drone. So that's a jointly procured and delivered drone that is now on the run and available. It's a state-of-the-art bit of kit. It's military grade, and that means it's able to fly in all sorts of adverse weather conditions and for a much longer period of time than our earlier drone. So in terms of fire service, what that does is it provides incident commanders and partners at incidents with much better situational awareness, which enhances both crew safety and assists in delivering a swifter resolution of operational incidents. And indeed, I speak personally, the drone was of excellent use for me at the largest incident that Hertfordshire Fire and Rescue have dealt with this year to date, which was a fire in an industrial building in Welwyn Garden City. In terms of police, the drone is able to provide support for when they are carrying out searches for high-risk missing persons, which I think the PCC referenced earlier this morning. So that enables us and the fire colleagues who fly the drone to assist with search on a much quicker basis. It's got excellent high-definition cameras and infrared cameras as well. The second area, perhaps I'll just highlight that's relatively new for service is on page 7, and that's something called GoodSam. So that's now fully embedded within police and fire. That's a video streaming service. It's quite revolutionary actually, because what it means is that people who ring 999 and either speak to police or fire control rooms can be sent a link and then live stream what they're seeing to the control rooms. The bit that works with us from collaboration is that those two control rooms can now share with each other that footage. And then indeed, police officers on the scene or fire officers on the scene can also stream back to the individual control rooms or share the footage both with police or the fire control room and then with other officers. So you can imagine the potential for use of this is huge in terms of keeping both police and firefighters safe and the shared situational awareness. And we're really starting to see the benefits of GoodSam now and starting to understand how it's going to be used extensively in the future. So that's just a couple of areas I touched on. I'm obviously very happy to the panel to ask me questions around any of the other areas, although I don't profess to be an expert in all of them, but I'll happily give an outline in some pending any questions. Okay. Thank you, Chair.
Thank you very much, Simon. And I understand from the report, this is the first time this report has come to this committee, and I think it clearly shows, and for those of us who've perhaps been members for some years, and especially those of us who've been district and borough councillors as well as county councillors, the collaborative nature of our blue light services working together across Hertfordshire, which I think most of us would agree. We're very fortunate to have such good joint working across the county. Quick question about GoodSam. Are we the only county who uses it, or is it replicated across the country?
So it's not universal across the country. There are other ways of streaming. Not every police or fire service use them. So some have different ways of doing it. Some don't use it at all. Certainly in the BCH collaboration between Bedfordshire, Cambridgeshire and Hertfordshire Police, they use GoodSam. Yeah. We're the only fire service in the Eastern region fire control collaboration that use it at the moment, but I do think our partners are starting to look at the potential for that, to make it roll out across all of the services, because actually if it's one service, if it's one system, it makes it a lot easier for both internal and of course for members of the public to understand as well.
Yeah, okay, thank you. Who have I got? John, sorry, I was going to say Judy. John, you've got your hand up.
Thank you very much, Chair. Just a couple of observations. One, I welcome the report. As has been said, it's the first time we've had it. I think it's very useful to see the extent and degree of collaboration that is going on. And I'm both disappointed that it's still necessary to be supporting the ambulance service and very pleased that you are, because I think they're going to have a difficult few months, and I think the support they can get from the other emergency services is going to be vital. And then a plea to the Chair. The Emergency Service Collaboration Board has now been in place for a few years, and I think every time it comes up at these meetings, I ask for greater transparency about when it's meeting, what it's discussing, and what its outcomes of those meetings are. I've had various promises in the past that there would be more said about it, and I've yet to see anything really come out of it. I think it really would be useful is if we did have reports at this meeting, periodically as to what they were actually talking about, and could then feed into those discussions. But that's just my perennial request.
Okay, thank you, John. Alex, I don't know if you want to come in there. Yeah, you've got your hand up. Thank you.
Thank you, Chair. John, I think taking your point, obviously as a recent joiner, the Collaboration Board is part of the remit that I sit on. I think perhaps useful for this panel if I took away an action from today, giving myself the opportunity to familiarise myself with some of the broader remit. I am aware of the MOU, I am aware of the arrangements and the governance arrangements, and I think the key principles around them, John, are leading from the MOU, which is all collaboration. What we'll then move towards is around having a number of programme boards that sit to look at property and other areas which are all about the best practice areas. But if I can take that action, Chair, to come back to this next committee with a broader presentation on the remit, responsibilities and the structures, I can work with colleagues in the PCC's office to bring that back here next time.
Thank you. Yeah, that would be great. Thank you very much, Alex. And thank you, John, for highlighting that. Okay, so no other intentions to speak. So panel is asked to note the Blue Light Collaboration 2021 annual report and its content. So if you could type in the chat box, please. Alex, you still have your hand up. Is that a legacy hand? Thank you. Okay, and that is item 9. That is noted. Thank you very much. Last item, which is item 10, which I know I took as a late item, update on public health initiatives, but I felt it was important because some of them were timely to present now. Delighted to have Joanne Doggett with us, Head of Programme Delivery and Resources. You've got the last slot, Joe, so you're going to have to work hard to keep us all awake and alert, but thank you.
Okay, I'll do my best. I'll try and keep it brief as well. Good afternoon, everyone. So I wanted to bring this paper because I think it's good news from public health. I think it shows some of the ways that we're doing more to make, really good use of our funding and target new initiatives to the people who need it the most. If I could just say at the beginning, I'm not an expert in the various different schemes that I'm going to talk you through. I'm just here to make you aware of the activities that we're going to be undertaking. And if this panel would like more detailed information about any of the areas that I'm going to talk to you about, then we'd only be too happy to arrange a more detailed presentation at future meetings. The schemes I'm going to talk through, funding for those will come from some additional government funding that we received last year and that we are anticipating will continue as part of our ongoing funding for future years, and also from the underspend that we incurred from last year's budget where services were reduced during lockdown. So the first point on the paper is around some additional commissioning team staffing. We're looking to spend around £240,000 on that. The core team for public health has grown significantly over the last 2 years. We're principally a commissioning service. And in order to be able to staff the initiatives that I'm going to mention in due course and continue to drive best value from our existing contracts, we're looking to recruit more procurement and commission expertise to the team. The next part of the report is around workplace health. Apologies, just having trouble with my screen. We're looking to invest around 1.3 million over the next 5 to 7 years around workplace health. As you'll be able to read in the paper, we already have done a great deal and we have a great deal of contact with workplaces. And this is a really important platform for us to engage with people about their health. Working is good for people for all sorts of reasons, not least that it helps lift them out of poverty. And this new scheme will allow us to do more to keep those in work healthy and also to tackle worklessness and get those people out of work back into work. We have a couple of schemes around defibrillators. The first is that Public Health have funded defibrillators and all of the necessary accompanying training at all of Hertfordshire's recycling centres in the county. That was approved, as I mentioned, in the summer, and they will be in place at all of those recycling centres early in the new year. And other defibrillator news, we're also funding a scheme to provide defibrillators in each county council ward. You may have seen communication about this that went out recently. As I mentioned, we're looking to, fund up to, I think, the 77, one for each ward, and we would encourage all councillors to take this offer up to install this potentially life-saving equipment. We're looking to spend around £60,000 per annum on women's reproductive health. This scheme will help to develop a more integrated model of care for reproductive services and form women's reproductive health hubs at primary care network level across the county. There was mention of the Building Life Chances programme earlier on today. Public Health have been awarded £280,000 as part of a £2.3 million scheme that will be funded by the County Council's Inequalities Fund to help address the impacts of COVID-19 on some of our most vulnerable residents. I'm sure there'll be subsequent updates on that. The next one is around the Daily Mile. The Daily Mile is a lovely scheme which encourages school pupils to get outside and walk, run, skip, hop, whatever, for a mile each day. We've been running it for a number of years and it's seen fantastic health benefits and really helps improve levels of concentration in children and so on. And this funding will help to further promote that scheme in schools and also extend it to preschools and nurseries. We're looking to run a healthy eating programme, which will cost us around £57,000 over the next 2 years. And this is for a 6-week cooking programme for small groups of families with children aged from around 5 to 8 years old. It aims to give parents the knowledge and skills to be able to prepare healthy meals for their families and support their children to maintain a healthy weight, which is obviously very important for health. Also on healthy weight, we're looking to spend around £87,000 on a teenage weight management programme, which will be part of our work to tackle obesity in teenage children, and also helps address some of the needs born out of the pandemic, where we know that more junk food and snacks were consumed. People got into some bad habits over lockdown. The scheme aims to increase knowledge and skills in this age group and for them to have a healthier lifestyle, leading to hopefully improved well-being and increased self-esteem. And I think it's the last one on the list. We also have a campaign called Never Too Late. This is a physical activity campaign for over 55s. This is a repeat of a very successful scheme that we ran in 2018, which encourages people over the age of 55 to be more active and as a result live longer, healthier lives. So those are the 10 areas that we're looking to invest in. I thank you for listening. I can do my best to answer any questions that you have, probably with Jim's help. But as I mentioned, if you'd like any more information about any of these schemes, I'd be happy to ask the relevant lead to come back and present at a future meeting.
Okay, thank you, Jo. I think with everything, it's about the outcomes. So it's great to hear about the projects, but actually how have they changed people's lives for the better is what I'm always interested to hear. And so maybe in due course something could come back with updates on that. Just because I've reached the age of over 55, is that really the, it always makes me chuckle because I don't feel old, but obviously clearly I fit into this new cohort where now I need to start moving, and I absolutely would accept that perhaps bad habits have been built up during COVID in terms of maybe snacks that have been consumed, so I'll include myself in that as well. Defibrillators, and I think that's a reminder to all members, if you haven't yet taken up this offer, then to have a defibrillator situated in your district, then please do look to doing this, so which is really, really important. I have somebody's hand up there. Colette, did you want to come in? Thank you.
Thank you, Chair. This is a very interesting report, Joanne. Good to see that we're targeting funding to address, I was listening to the comments about getting youngsters out of the bad eating habits that they've acquired over the COVID lockdown period. There's no mention of any extra support for the many adults who've taken solace to having lots and lots of alcohol, and clearly that isn't good either. Are we focusing in any extra effort in those areas? So, for example, AA, which is, as I understand it, a mainstay for many people, wasn't able to hold meetings and so on during the lockdown period. And I just wondered what your view was on what I've just said. Thank you.
Yeah, absolutely. I think we recognise, increased consumption of alcohol and also misuse of drugs has been an issue during COVID. Yes, we have a number of different programmes to work around drugs and alcohol. We can certainly bring a more detailed update of that. Again, I'm not the expert in that particular area, but Jim, did you want to come in with anything on that?
The only thing I would say very quickly, Chair, is we have expanded funding for arrest referral and various other programmes, and we've got some extra money from Public Health England to do some work. If there were voluntary organisations that were finding themselves struggling with re-establishing, like AA, and needed a little bit of start-up funding to hire a hall, then obviously I think I can see the Chair nodding, but Maurice and Fiona have asked us to do everything we can to support. So if there are things you think we can do, let us know and we'll help. We'll try to help.
Okay, thank you. Does that answer your question, Colette? Thank you. John.
I'm going to ask what may seem about a daft question, but occasionally I think a daft question is worth asking, and I'm reasonably certain of the answer because both areas come under Jim. But I assume there is coordination and cross-pollination, whatever the right phraseology is, between the initiatives on here which relate to weight and food and the whole good obesity strategy. Thank you.
Yeah, good. Short answer. Thumbs up from Jim. Yes, thank you. Thanks for your question, John. No, just checking. No, that's nobody else has any hands up. Thank you, Jo, for presenting those. Lots of good work happening, and yeah, look forward to seeing outcomes in due course. So thank you. And Members, we are asked to note and comment upon the content of the report, and a request from Jim, the Director of Public Health, is asking us to support the schemes mentioned by helping to publicise them in due course, which of course we will all be happy to do. And if you could just put your vote in the chat box, please. Just waiting to see. Everybody has done that. Looks like everybody has. Just wait for official confirmation. Yes, we have. So that's noted. Thank you very much. Item 11, any other business? There's nothing urgent. Part 2, closed agenda. There is no part 2. And the date of the next meeting, just for your diaries, is the 1st of February 2022. It's probably too early to wish everybody a happy Christmas, but thank you very much, everybody, for your attendance this morning. And thank you for bearing with me in Maurice's absence. And I expect Maurice will be chairing the next meeting. So thank you, everybody, and have a good afternoon. Thank you. Thank you, Judy.
Thank you, Fiona.